Good afternoon, everyone, and welcome to the 2024 VBID Center Summit, Overcoming Financial Toxicity. My name is Susan Lynn Osterly, and I'm the Program Manager for the VBID Center. I'd like to go over some logistics. We would like the summit to be as interactive as possible. Attendees can send questions and comments via the Q&A tab on the Zoom control panel. Given the format of today's session, time constraints will limit the number of responses to audience questions, but we're always welcome to questions, comments, and feedback at vbidcenter@umich.edu. And now I'd like to hand things over to Dr. Mark Fendrick.
Good morning, some people. Good afternoon to others. Susan Lynn and the entire VBID staff, I can't thank you enough for all the dedicated efforts you put in to make this summit possible. Next slide, please. It is a great pleasure to reconvene. This is our 20th summit. We first got together in 2005, and some of you know, seeing the participants who've been with us from the beginning, the VBID idea was supposedly conceptualized over a $5 bibimbap at Kang's Korean restaurant. By the way, that now bibimbap is now $10. And there you see myself and my close colleague and VBID Center co-founder, Michael Chernew, sitting listening to the first summit in 2005. Next slide, please. For those of you who've heard this before, I apologize. This is my mother, who's turning 90 this month, who, when I told her after talking with Mike about the problem with cost sharing and our efforts to reduce them, she said, "I can't believe you had to spend $1 million to show that if you make people pay more for something, they'll buy less of it." Thankfully, many of you, the many collaborators and friends of the VBID Center, know that my mother was right. And thankfully, when she said, "I can't believe you had to do more studies to show that if you make people pay less for something, they buy more of it," thankfully, our mothers are always correct. So next slide, please. So for almost 20 years now, Mike, myself, the VBID Center staff, and our amazing advisory board who met yesterday has collaborated with stakeholders across the board of the healthcare continuum to identify, evaluate, and implement strategies that improve access, enhance equity, and improve efficiency of the healthcare system. And in our second 10 years, we've actually focused a little bit more on the identification, measurement, and removal of low and no value care. Next slide, please. So I'm very excited to convene this year's summit. We'll be touching on several initiatives that the VBID Center is working on with a particular focus on equity enhancement and disparity reduction. These include the preventive services provision of the Affordable Care Act and the legal threat to that provision in the Braidwood versus Beshara case. We'll be talking about high deductible health plans. We'll be talking about access to medications, and we'll have a specific panel on how hard it's been to address this issue of low value care. Next slide, please. So all of this would not happen if it wasn't for our sponsors, and you see them all listed here. We've always been particularly proud to see multiple stakeholders, from payers to health sciences companies to benefit consultants to patient advocacy groups, who support our work to reduce out-of-pocket costs and enhance utilization of high-value services. And completely coincidentally today, next slide, please, is something called Giving Blue Day here at the University of Michigan. And for those of you who might be interested in supporting the center, I've been thinking about it, you will see in the link a specific link to the VBID Center if you feel so compelled to support our work. We're nonprofit, we're tax deductible, and any size of donation will help us continue our efforts. So with that, next slide, please. I am absolutely thrilled this year again to introduce my very close friend and amazing colleague, Cliff Goodman. Cliff has been with us at the VBID Center almost from the beginning. We do not have VBID summits unless we know Cliff could be around to moderate them. We are thrilled to have you here, Cliff, today. And with that, I thank all of you for participating, the registrants, which we hope to have around 700, all the panelists who've given up their valuable time, the VBID Center team, and of course, you, Cliff. Take it away, buddy.
Thank you very much, Mark. Glad to be here, and actually honored to be here with this group. And I know that over the years, we've had so many people revisit these summits, and we've basically all learned together in real time. So for today's webinar agenda, checking this out, We're going to have 4 main sessions, the first one of which is going to address high deductible health plans at 20 years. Basically, what have we learned about these plans since they were put in place 2 decades ago? There have been successes, but there's certainly been challenges. And certainly the kind of backdrop in the healthcare system has changed dramatically. So these really bear a more careful look at this juncture. The second session is going to look at enhancing preventive services use. Again, speaking about backdrop, what about the backdrop of Braidwood versus Bashara? That is pending in the federal courts. That could go a long way toward improving or cutting off access to these preventive services. So that bears careful scrutiny. We'll have a 15-minute break. Then following that, our third session is going to look at enhancing access to essential medications. Clearly, the issue of what medications are essential, what has improved access or enhanced it, and what is also getting in the way. Obviously, there's some things going on at CMS and Medicare with certain medications that also come to bear. And then our fourth session is going to be kind of a pragmatic kind of look at this. Why is it so hard to reduce low-value care? We all have ideas about why this should be done. We've had ideas and programs and initiatives to make it happen, but it hasn't been an easy go. And so we're going to take a very careful look at that. So those are our 4 main sessions. We'll have some closing remarks toward the end of the afternoon. So that is our main agenda. With that, I'd like to go to our first session. And this is on high deductible health plans at 20 years, successes and challenges. I'm going to ask each of our 3 speakers, Frank, Stephen, and Katie, to first give us sort of name, rank, and serial number, and what is it about this panel that aligns with what you do? How do you find yourself on this particular session? And Frank, if you get us started and set a good example.
Okay, thank you, Cliff. I'm Frank Warham. I'm a general internist health services researcher at Duke University and professor of medicine. I and my team have been doing research about the impact of high deductible health plans on healthcare use and outcomes for about 20 years.
Great, thanks, Frank. Stephen.
Okay, so I'm Steve Parenti, professor of finance and also a health economist at the University of Minnesota. I have also been doing a ton of work on consumer-driven health plans, but most of my research has been looking at, in the more recent years, simulations of what would different designs of these plans look like in terms of projected budgets, nationally, take-up rates, and what they would do for a particularly vulnerable population.
Thank you very much, Steve. Those models have been very valuable. And at this point in the evolution of these plans, there's a lot of uncertainty there. And we look to modelers such as you to help us out on that. Over to Katie.
Great. Thanks, Cliff. Hi, I'm Katie Spangler with Spangler Strategies, and I'm also co-director of the Smarter Healthcare Coalition, which is a very diverse coalition based in Washington, D.C., and we are focused on increasing regulatory and legislative flexibility for high deductible health plans that are coupled with health savings accounts to be offering more high value care on a pre-deductible basis.
Excellent. Thank you very much, Katie. So I'm going to turn to Frank next, and each of our 3 main speakers is going to have about 8 to 10 minutes to kind of lay out some initial main issues, kind of the high points. We'll use the balance of our time for some Q&A and some discussion. And just, Frank, I know that these high deductible health plans they've got higher deductibles than a routine or traditional health plan. And they also have lower monthly premiums. And so how has this played out in your view, Frank?
Yeah, thank you, Cliff. Yeah, and you laid out what a high deductible health plan is. And so maybe I'll just fill in a little bit there. But yeah, I really want to talk about 2 main issues. And so, if we're talking about 20 years, first going back 20 years, and what were the open questions or the important questions about high deductible health plans 20 years ago? And second, what have we actually learned in the last 20 years from research about high deductible health plans or societal trends? So as you said, high deductible health plans have higher deductibles, lower premiums. Just want to clarify that some people consider a high deductible health plan only if it has a health savings account attached to it or health reimbursement arrangement attached to it. I think I'll take a broader definition that many people, sort of the Kaiser Family Foundation definition of a plan with a deductible of at least $1,000 for individuals and $2,000 for families. And most services are subject to the deductible. Of course, it's important to note that from very early on, most high deductible health plans had some value-based exclusions. So primary care visits and preventive care. And if it were a non-HSA, non-health savings account plan, a plan that has tax advantage dollars that you can use to pay for health expenses, those plans often excluded prescription drugs. So, and then as this audience would know, since 2010, because of the Affordable Care Act, that required evidence-based preventive care to have $0 cost sharing. So I'm going to say a typical modern high deductible health plan has a deductible of at least $1,000 and VBID features. And again, as this audience knows, this matters because about 2/3 of the privately insured now have high deductible health plans. Half of these are in health savings account plans, half in non-health savings account plans. And this amounts to about 1/3 of the entire US population. And that matters because many people are concerned, like like Dr. Fendrick's mother, that high deductible health plans will have some concerning effects, reduce utilization, and cause financial and even physical harm. So, I thought to understand the last 20 years of research about high deductible health plans, it's important to first know about the preceding research. So 20 years ago, what do we know about high cost sharing? And that's really going to boil down to understanding an important study that many here might know about called the RAND Health Insurance Experiment, because it set the stage for subsequent research and findings. So the RAND experiment was in the 70s and 80s. About 8,000 adults were randomized to very high cost sharing, very low cost sharing, levels in between. And the high level takeaways were that very high out-of-pocket cost obligations were sort of a blunt instrument, sort of reducing all types of care, whether they were needed and high value or less needed and low value. And there's an exception that high severity emergency department care didn't decline as much, but in general, all services went down. Because of this, high cost sharing was found to reduce healthcare spending. No surprise there. If you reduce the use, you're going to reduce the spending. And then a third major takeaway from that study was that there was no observable impact on health outcomes, except for a subgroup of people who were low income and high morbidity. So they were predicted to have adverse health outcomes. I think it's also important to know that 20 years ago, we didn't have research about this modern sort of high deductible design that has value-based exclusions. That just wasn't part of the body of research then. So I thought I would raise sort of 7 major questions about high deductible health plans that existed 20 years ago. And several of these questions were raised by sort of the RAND health insurance experiment. Would these play out in the modern high deductible environment? And other of these questions were raised by high deductible proponents and high deductible critics. So let me go through these questions, and I'll try my best to summarize what I think the answers or lack of answers we've gotten over the last 20 years. So these first 3 are really sort of related to the RAND health insurance experiment. How will that play out? So will reductions in service use among high deductible health plan members be indiscriminate, sort of this blunt instrument, or will patients distinguish high from low value care? And I think it's been very clear, actually, that when you have exclusions of high value care, such as cancer screening, prescriptions, cholesterol testing, diabetes monitoring, when those are excluded from the deductible, sort of a value-based exclusion I talked about, those are preserved. I've seen many studies, I've conducted many studies that have shown that those types of services, those high value services, are preserved when they're excluded. Interestingly, maybe less well known, there's also a pretty good evidence that high value care is preserved even when it's subject to the deductible. We've done studies about people with bipolar disorder preserving psychiatrist visits, cancer patients preserving oncologist visits, diabetes patients and HSA plans preserving specialist visits. Now, this isn't always the case, but that's a lesser known, I think, phenomenon under high deductible health plan. On the other hand, we do see that maybe people might be, there might be offsets. People might be reducing other forms of care to preserve the type of care that's important to their major health condition. And I'll also say that it's also clear that there are reductions in high value, expensive care, medications. Many studies have shown that medications decline when they're subject to these high deductibles. Okay, so second question, sort of related to the RAND health insurance experiment, will high deductible health plans reduce healthcare costs and premiums, Or will the potential harm that they might cause lead to no cost savings or even increased costs? And then here I might defer to my economist colleagues, but I think research here has been pretty clear that high deductible health plans do reduce healthcare costs. You see estimates in the range of 5 to 15%. So modern high deductible health plans are associated with reduced healthcare spending. Okay, third question related to the RAND experiment. Will high deductible health plans worsen health outcomes broadly or not at all, or among lower income and chronically ill patients only, as predicted by the RAND health insurance experiment? Here, I think we have a sort of not a lot of research. There's been a handful of studies. We found in a study that there was no overall impact on major adverse cardiovascular outcomes among sort of a broad population of people with cardiovascular risk in high deductible health plans. On the other hand, we also found that high deductible health plans are associated with increased acute diabetes complications and high severity hospitalization days among low income diabetes patients. So that's three questions. The next sort of four questions I want to talk about were sort of hopes or expectations raised by proponents of high deductible health plans. So let's see how those played out. So fourth, will high deductible health plans facilitate the expansion of health insurance? Those of you who are familiar with the employer-sponsored market might know that especially small employers often face a choice of having either no health insurance or a high deductible health plan because they have lower premiums. So one could argue that high deductible health plans have helped preserve health insurance coverage among especially those smaller employers, although others would argue that that's really kind of an expansion of underinsurance for those employers. And then the Affordable Care Act really expanded health insurance at the state level through high deductible health plans. The state marketplaces that were set up really sell high deductible health plans. So, and there were other provisions in the ACA, like the Cadillac tax, wasn't enacted, but that were really, it seems, meant to promote the expansion of health insurance through less generous high deductible health plans. Fifth question. Will high deductible health plans enhance price awareness or even financial toxicity awareness and price transparency? I think we've all seen the popular media stories about health cost shocks, the cost of drugs like semaglutide, insulin, EpiPens. We've seen legislation like the No Surprises Act, insulin out-of-pocket caps, executive orders like the hospital price transparency rules. So I think it's fair to say there's been a lot of publicity and policy interest in prices. And, I think you could attribute a good amount of that to the prevalence of high deductible health plans where people are just seeing their out-of-pocket costs a lot more than they might have in the past. Sixth question, again, this is related to, some of the predictions of proponents. Will high deductible health plans promote value shopping and therefore price competition among providers? I don't think there's been a lot of research here. I only know one study, and it really didn't show evidence of value shopping. And just looking at the situation as I see it as a clinician and as a researcher, in the current conditions, I'm not optimistic that value shopping and price competition among providers will happen because of high deductible health plans. And seventh and final question, will people in high deductible health plans improve preventive care and improve their health in an attempt to reduce out-of-pocket costs? This was one of the arguments of some proponents, and I can pretty confidently say that the answer is no. Here, I haven't seen a high deductible study that shows that people became healthier or used more preventive care. Okay, so what do we know about high deductible health plans in 2024? Let me summarize all of what I just said briefly into four basic realms. So the behavioral response of members to high deductible health plans. I don't think high deductible health plans in the current form are a blunt instrument. Patients do respond to the VBID features. In terms of needed or appropriate care, that's subject to the deductible, we do sometimes see preservation of even these services, but on the other hand, we see concerning reductions and offsets in other types of care. So that's sort of a mixed picture. Effects on patient health. There's no evidence that high deductible health plans make overall population sicker. But on the other hand, they don't make members healthier, and they might worsen health outcomes for low-income, high-morbidity patients based on existing research. Third, effects on costs and coverage. High deductible health plans reduce healthcare costs and therefore facilitated the expansion of health insurance. But some would say this is really just the expansion of underinsurance. And then fourth, the promotion of optimal market conditions. There's certainly been increased societal and policymaker awareness of health healthcare prices, but it seems unlikely that high-deductible health plans are promoting value shopping and therefore price competition. So that's my take.
Frank, that ain't a bad take. You covered a lot. The conclusions that you just derived and summarized came from examination of 7 questions. We really appreciate that coverage, distinguishing between high versus low value care. Do they reduce spending? Yes, no. What about the outcomes? Do they expand health insurance or not? What does it do to price awareness and toxicity? Do they value shop or not? And do they improve preventive care? And the answer to that one was no. So that is a wonderful overview. Really appreciate that. We're going to come back to some of those points, I think, in just a bit. Thank you, Frank. Steve Parente, we're going to move over to you. And how do you kind of think of this in terms of the modeling universe, Steve?
Well, thanks, Cliff. This has been a fun journey for me. Actually, for me, this is about a 24, actually, if I really count it right, about a 26-year journey. I actually studied these when they were medical savings accounts, when they came out of back with HIPAA. And interestingly enough, I wasn't at the University of Minnesota. I was at Project Hope Center for Health Affairs at that time, later NORC. And we got a giant study from the GAO to say, what's going to be the impact of these brand new medical savings accounts? And we had to give the money back to GAO because no one signed up for them. So that was my first foray into this space. Later, moving to Minnesota, the nice thing about Minnesota is that, particularly the business school, is that we have a lot of innovative ideas that come out of here. HMOs, with going back with the designs from that came from Paul Elwood, came from Minnesota. United Health Group came from Minnesota. And all the stuff that comes along with it. But more importantly, Definity Health and Luminous and a bunch of other firms that were startups in this space in the 2000s were things I started to track. And they let me actually look at all of their major employer data funded by RWJ to figure out, first of all, whether or not there'd be adverse selection problems in terms of what was going on. And actually, the RAND health insurance experiment that Frank mentioned was key on our mind. What was interesting was that the developer of these plans also read the RAND health insurance experiments. They were former students that actually learned about that stuff, and they made primary prevention required to actually be in the benefit design and Definity to avoid the issues that the RAND health insurance experiment talked about. So one thing we also found when we looked at selection was that it turns out that chronic conditions were not the thing that everybody thought would keep people away from these plans, at least initially. It was actually income would be a correlate of whether they'd go into them or not, actually. And it was a different design. It was a much more generous HRA design. Matter of fact, we tracked them long enough to realize in the case of one very large employer, a tech company, they actually made their design so generous that it actually was creating a moral hazard problem for their plan design. And they actually had to increase their deductibles to get things under control. Wow. Now, those are your grandmother's high deductible health plans. Today, they're much more tighter in terms of deductible limits and co-insurance. Just to give you a perspective, that one employer I mentioned had every family got an account of $2,000. This was in 2002, and the deductible threshold was at $3,000. So their donut hole was $1,000. That's not a big donut. So one thing that came out of those studies was we had a ton of choice information, knowing how people would choose these different plans. And lo and behold, the MMA created the health savings account market. We actually got a study paid for by ASPE at HHS to forecast what might happen if these were entered into the market. There were lots of speculation in 2004, the first plan offering year. And my team with Roger Feldman, John Christensen, Minnesota, we actually came pretty darn close. We forecasted about 2.4 million people would enter the market. It ended up being about 2.2 in that first year. Many people were off by 1.5 million, I think, from one other studies I saw from other places. One reason why we were thinking that we had a pretty good model was that we were factoring in all the right economic inputs, chronic conditions, whether they had them or not, whether or not what their income level was, so SES status. So it's a much more complex model than what normally would have for those choice variables. And then subsequently, we used those that actual complex model to model a lot of other things that would happen in this plan design, which gives me to chapter 2. I know Katie will talk about some of the tax changes that were made. One of the big concerns about these high deductible health plans was that they did not have anything for folks with chronic conditions, particularly diabetes, asthma, depression, and other things. So actually working with folks from the VBID Center going back now, actually over 10 years, we tried to model what would happen if we inserted that as a new benefit design, if we actually made secondary prevention, that is basically pre-deductible paid care for folks with diabetes, with asthma, and got specific, actually figuring out what's the PMPM cost and the premium, factor that into a new model, see what people would move it differently. We actually had to make some pretty big assumptions about perturbing some of our variables of folks with chronic conditions, see whether they would move one way or the other, given what their choice sets were. And so in the end, we actually used that work to, at the very least, come up with a prediction that it would actually save money and more people would move to what we call an high-deductible health plus model market. As I mentioned, Katie will talk about what the outcome of that is, but basically that model was just by coincidence in my hand in 2019 when I worked in the White House, and someone from HHS said, there's a proposal moving around Treasury. They want to have a price point to understand what things should be included in the parts list for this new legislation, or actually rule change, that will come from Treasury guidance. And it just so happened we had the parts list with PMPM to see exactly what would be there. And we actually knew. So I pulled out my old results going back to 2018, right before I was in the White House in 2019, just to basically say, like, different models, whether everybody replaces them with these designs or off them side by side. And it turns out the number that we came up with, what the truth was half the plans offered these new designs ended up pretty darn close to the truth in terms of the take up and who would actually get into those markets. Not quite as good as our 2004 Health Affairs study, but not that far off either. What I'm working on now is imagining a world where we can expand that coverage. What if we actually made secondary prevention even more expansive than what it is now? Well, that was one of the complaints that came out in 2019, was that it should have been more expansive than just the list that we had. And so I've been working to add more drugs in there, particularly for chronic conditions. Also adding full primary care for folks with chronic conditions as well. And then even the provision of direct primary care as another component. What we're finding is that adding those pieces into premium, from what we heard from experience, is not that expensive compared to all the other components of what's going on into the market. What we see is what you would expect. More people will gravitate towards those types of plans. What we're missing, and this is for the question for the future, myself, whether it's Frank or others that are there, is what is happening in these plans. We know that people are selecting these new types of, if you will, high deductible health plus designs. What we don't have is the claims detail information to tell you what the RAND folks found before, what I found before, about whether or not costs are moving up and down, are health outcomes being affected, are people getting more of the services that they need, and we track them longer term to see modifications in behavior that we would expect in that space. It's the ideal world, and actually I'll make the offer to anybody on that's watching or anything else. It works best if this is coming from employer data. You need to have employer data that includes the full benefit choice set, so we know what the alternative choices are that they're choosing against, and the claims data that goes along with them. I've had 30 years of handling sensitive data. I'm good at it. We've never had a breach, but that's the best way, whether it's my shop, Frank's shops, anybody's shop, to try to figure out definitively what these new designs are doing, which I think are quite empowering. And then the last thing I'll mention, 15 seconds to go, is when we talk about all the price transparency stuff that's in the future that needs to be there, that has to be layered on as well. We don't know yet what these tools might do. The most limited thing we ever found from our previous work was that if you tell folks the pharmaceutical prices, they will go down. But we don't have the tools yet to see the full picture. And with that, my voice is gone.
Well, Steve, your voice ended just in time because you had, I think you laid out a half a dozen great issues here for further consideration. It's so interesting how the RAND experiment has had such a long tail insofar as its influence since, I think the first report I saw of it was 1977. It's been a while. You got into choice making and the nuances around that. You emphasize the role of secondary prevention of chronic conditions, which is an increasingly important role. You talked about how you might even model expansion of secondary prevention, where they're adding drugs, full primary care as well. You emphasize the role of employer data, and Katie might be one to comment on that as well. And then you talked about price transparency. What's it really going to look like? It's hard to know what kind of impact it might have if we don't kind of understand how that's going to roll out. So Steve, great points. So Katie, both Frank and Steve have put some things on your plate now. Both of them referred to stuff Katie's doing. And I know you're going to talk about some survey data and some other findings, expansion of the preventive services. What do you have for us, Katie?
Great. Thanks, Cliff. And maybe just one more second on my background. So I actually was working in the United States Senate in 2003 when the Medicare Modernization Act was passed, which had this section that created health savings accounts within the US tax code. So for the past 20 plus years, I would say I have been working on health savings account issues. A lot of the more recent work, I would say in the last decade, has focused on expanding what can be offered on a pre-deductible basis. And so was delighted with the progress that we made thanks to Dr. Fendrick's leadership, Dr. Chernu, as well as Steve Parente, to really expand what could be offered pertaining to chronic disease prevention. So when the law was created in 2003, as folks know, there was a safe harbor for preventive care. But when those regulations were published and that sub-regulatory guidance was published in 2004, there was actually a very narrow definition of what constituted preventive care. And so we worked for over a decade to expand that list to include more chronic disease prevention, because previously the rule had been that if you could screen to find out if someone had a disease, but once the diagnosis was made, anything to treat that condition could not be provided pre-deductible. But given kind of all the data that we have talked about on this call already, our country spends $4.5 trillion on healthcare every year. About 90 cents of every healthcare dollar is used to help manage chronic conditions or treat chronic conditions. So if we can do a better job of that on the front end, you can imagine just the potential savings that could accrue to the system, not to mention if a patient with a chronic condition is better enabled to manage their chronic condition, their entire way of life is going to be drastically improved. And so this really is an example of a 1 + 1 = 3 in my mind, just policy goal as far as expanding what can be offered on that pre-deductible basis. So we said for several years, going back several administrations, we kind of made the case of if you build it, they will come, or if we build it, they will come. We had said that if employers and health plans were granted more flexibility to offer additional chronic disease prevention pre-deductible, that they would do it. And we said this a lot. We said it early, we said it often, we said it over multiple administrations. We were delighted that the previous administration took us up on that, and they did expand, as Steve mentioned, to allow 14 additional drugs and services to be offered on a pre-deductible basis. That was in 2019. That guidance document is Treasury Notice 2019-45. And we then spent the next couple of years trying to understand exactly what happened. And, we knew we had said this and we wanted to see if we were truthful in what we had said. And so the Smarter Healthcare Coalition, of which I am co-director, partnered with America's Health Insurance Plans, or AHIP, who is a member of the Smarter Healthcare Coalition. They surveyed their members who represented both fully insured health plans, but also in partnership with employers representing self-insured health plans. And what they said is that after the survey data came back in, we saw that between 75 and 80% of health plans and employers actually changed their benefit designs to offer more chronic disease prevention pre-deductible. So we were very delighted with that finding. I'll never forget Dr. Fendrick politely and kindly encouraged me to not get too excited because he was a little nervous that maybe those results wouldn't hold up. So you can imagine my delight when about a month later, the Employee Benefit Research Institute and the great work of Paul Fronston affirmed that result with his survey results, which showed that 76% of responding employers made changes to offer more chronic disease prevention pre-deductible.
So Katie, can you just say that one more time? It's such a key finding. Can you capture it one more time in kind of a kernel?
Yes. So between 75 and 80% of employers and health plans that responded to the surveys made changes to offer more chronic disease prevention pre-deductible for their employees.
So definitely kind of a cause or intervention and impact directly tied, correct?
Correct. And we drilled even further, Cliff, and we asked them, okay, so which things did you offer? the majority of respondents said that they offered things to help manage diabetes pre-deductible, which, many folks are aware how tough it is to live with diabetes. And so for the patients with high deductible health plans, that's a terrific benefit for them. And then second up was heart disease. And so also really important and really prevalent in society. So those two findings alone were very helpful to know. Paul Fronston in his work through eBree also asked employers, if you were provided additional flexibility, would you utilize it? 81% of respondents said yes. And so that's another thing that we're really working, and I think adds a lot of wind in our sails as we work to expand what could be offered pre-deductible. And so as part of that 2019 guidance, Treasury and IRS said that they would look to update the current list of 14 items and services, that they would look to update that every 5 to 10 years. We are now 5 years out. And so we have been knocking on the door for over a year to say, hey, remember us? We pushed you to offer more chronic disease prevention, or to allow coverage of more chronic disease prevention pre-deductible. It happens, between 75 and 80% of folks actually did it. We would really love for you to expand the flexibility to additional high value services. And so that would include things like mental and behavioral health counseling. I think certainly coming out of the pandemic, we've unfortunately seen the need for additional mental and behavioral health counseling. Additionally, things like naloxone to treat drug overdoses. Also very interested in some primary care visits being allowed to be offered pre-deductible, as well as even potentially specialty visits. One thing that we have heard from survey respondents is that it's difficult sometimes for a patient. It's great that their insulin could be offered pre-deductible, but if the visit for the prescription for the insulin is not pre-deductible, that erects a new barrier for some patients. And so we would love to see some of those primary care visits be able to be offered pre-deductible. Cliff, I could go on, but I don't want to forestall conversation and discussion.
No, those are great points. And again, the impact on the employers and the fact that they really took these findings to heart and actually acted on them in short turnaround is important. And you substantiated the point that Steve made about how important employer data are. So that's a big idea. Insofar as the last 20 years, we've learned about who responds to what kind of stimuli, and those are good lessons to take home. I'm wondering, Frank, having heard what Steve laid out from a modeling standpoint and expansion of secondary prevention, what Katie just pointed out insofar as employer responsiveness, how might those findings or trends affect your work and what you're looking forward to?
Yeah, that's a great question, Cliff. Interestingly, we kind of already know in some sense. There's as I mentioned at the beginning, high deductible health plans for many years have excluded certain services from the deductible. Now, those aren't the HSA, although not necessarily the HSA eligible ones. High deductible health plans that aren't HSA eligible will exclude certain services from the deductible. And I have to say, even HSA eligible ones, there's some gray area around whether medications could be offered pre-deductible. And so some major national health insurers were offering medications for secondary prevention of chronic illnesses pre-deductible. And so, we've been doing studies about that. And we recently published a study showing that when an employer purchases one of these plans that make a whole large list of preventive medications $0, that not only increases use of those medications, and that's sort of the VBID finding, but it also improves diabetes health outcomes. We found an association with reduced days that people experienced acute preventable diabetes complications when they transitioned to a plan that made their medication $0. So, and then there's been pretty clear findings that when you transition to a high deductible health plan that keeps a lot of those preventive services that Katie's talking about, not subject to the deductible, sort of low cost, those are preserved. So my reflection is that that the efforts on behalf of HSA plans are probably going to be successful in preserving care and hopefully improving outcomes. And that's what we've seen in sort of early studies about that type of design.
Excellent. Steve, in your modeling work, whether it's secondary prevention or otherwise, to what extent are you able to model or forecast the impacts of things like GLP-1s and naloxone for opioid use disorder and other technologies coming along? Are you able to sort of accommodate those, and do those have any meaningful impact on your modeling, your model findings?
It depends on the overall price. So for the GLP-1s, it definitely could, because if you think about some of the things that we're talking about for adding, say, primary care or mental health in terms of what's the PMPM impact on that, they're present, but they're not that significant. Right now, the GLP-1s, as they are on brand, with Ozempic the way it is right now, I mean, that would have a major impact. It's sort of like the same way when the Hep C vaccine first came out. I mean, that almost blew up the the secondary risk market. So yeah, I think that one illustration might be a little bit off, but if something that's more common, not a blockbuster drug that's sweeping the nation, then I think it would be different. Now, the question is to what extent, and I teach a pharmaceutical policy class, so I need to answer this question before Saturday, but to what extent we have the substitutions for GLP-1 or other things that are available that could lower the cost is a different issue. I know a lot of people are getting them through compounding, which is not what the compounding laws or restrictions are supposed to be doing for. So there's lots of, the question is whether or not the outcomes really justify what's going on there, whether they could be factored in. But yeah, that should be probably something that would be added to the list, as long as it doesn't blow up the model and the outcomes justify the long-term impact.
And you probably have to be aware of kind of how prices would change given the market factors and so forth. Right. Katie, can you sort of come back to the issue of how secondary prevention is viewed by policymakers and legislatures and so forth? Do they get secondary prevention, or is it still seen as something, well, you've had a problem diagnosed, this is about treatment, not prevention? Is that still an issue?
Yeah, so I think that there is a deepening understanding of the importance of addressing chronic disease, right? So I think of secondary prevention as, if primary prevention is screening to find out if you have the disease, and if secondary prevention is actually treating that chronic disease, I do think that there is an increasing emphasis on this. As I mentioned, right, the CDC has estimated that about 90 cents of every healthcare dollar is used to manage chronic disease in some way. And so certainly Congress understands this, especially with regard to the Medicare program.
They do? Okay. Mm-hmm.
And there have been a lot of different bills really targeted at Medicare spending and trying to do a better job of helping Medicare beneficiaries with chronic disease. I think kind of the work that the Smarter Healthcare Coalition has done in partnership with the VBID Center is really to broaden that work and make it also applicable within the commercial markets. And where we've seen probably the biggest barrier to flexibility with benefit designs pertains to plans that are coupled with health savings accounts.
Okay.
Some folks have asked, like, why are we focused so much on high deductible health plans that are coupled with health savings accounts? And that's because those are the plans that are regulated at the federal level by Treasury because of the tax implication of the health savings accounts, right? And so health savings accounts are the only thing in the tax code that have the triple tax advantage of you're able to invest in your health savings account on a pre-tax basis. The amount that's in your health savings account can grow tax-free, and then you're able to withdraw those funds without paying taxes on them. And so there's no other kind of unicorn within the tax code that has all three of those tax advantages. And so that's why these plans, the high deductible health plan in which you have to be enrolled in order to make or receive a contribution to a health savings account, those are pretty closely regulated by Treasury and the Internal Revenue Service, because of that connection to the tax benefit. And that's where really the barriers have arisen with regard to implementing more value-based care and value-based benefit design, and especially on that pre-deductible basis, because they're regulated so heavily by Treasury and IRS.
God, it's interesting you're saying that, because Adam Finkelstein just asked about the status of health savings accounts, and I think you got into that very nicely. And I have to say that we got a question, maybe a bit of a tongue-in-cheek question from David Kendall. Said, hey, why not make the GLP-1s for weight loss pre-deductible? There's something to mull over for you, Steve. Question back to Katie, having to do with the employers. Monica Van Buskert asks, what kind of flexibility would be appealing to employers? Did you learn what else they're interested in expanding? So giving some employers some leeway. What do you think, Katie?
Yep. So we did ask that question. Overwhelming response pertained to the primary care, kind of an office visit. So either a primary care visit or maybe even a specialty visit, for example, to an endocrinologist if someone has diabetes, or a cardiologist if someone has heart disease. We also heard about telehealth and the strong desire to continue to be able to offer telehealth on a pre-deductible basis. I'm delighted to say that there is current flexibility to offer telehealth pre-deductible in these health savings account eligible plans. But the bummer there is that that flexibility ends at the end of this year. This was something that cropped up in response to the pandemic. It was in the CARES Act that passed in March of 2020 to grant flexibility. Congress has renewed it several times. I do expect that they will renew it again, but I will say it's a little tough if you're an employer and you're planning your benefits. You know, you don't wait until Congress passes something in December to really plan your benefits for the next year. And so that's why there's a big push to make some of that flexibility to offer telehealth pre-deductible, to make that permanent.
Got it. Question for Steve, although others can comment as well. This came in from Chris Saxman. It has to do with these things starting to look a little bit like MA plans. And so these additional services that Steve and others have described sound like supplemental benefits that Medicare Advantage plans offer to compete. Can there be any comparison between these two realms for analytical purposes? Steve, you have a take on that?
Yeah, I mean, it could be. I mean, there's obviously a choice model in terms of people choosing a more traditional path. So you could think of, I'm going to take a standard old PPO versus take a high deductible health plan market, assuming the employer offers both. There's a lot of employers that don't offer both and offer just one choice, full replacement, for example. But I mean, I think there is a difference. I mean, some of the things offered for MA are really extensions of social services. We're not proposed. I mean, some of the things, maybe the counseling stuff that we're modeling as the new models sort of get there. But most of these things are generally thought of as they're in medical care. They got CPT-4 codes or they got NDC codes. They're not necessarily a special transportation service or something else like that to get folks to doctor's appointments. I think they typically fall in that realm to be qualified medical expenses.
Got it. Got it. Question here from Risha Gawani, and this is a little kind of heavy here, but it has to do with favorability towards HDHPs that have with HSAs. So wants to hear the panel's thoughts about why, follow me now, why so much proposed legislation favors exempting services from the deductibles of HDHPs with HSAs when there are a large amount of people enrolled in plans with greater than 1,400 or 2,800 deductibles, yet don't have HSAs, who then don't enjoy the benefit of having services not subject to deductibles. Why, and that's being posed here, why are HDHPs with HSAs being favored so much relative to other HDHP plans? Frank, do you have a go on that, a take on that?
Yeah, I do. I mean, that's a little nuanced, right? But
it is.
What's happening with the health savings account plans is, as Katie and Steve mentioned, they're regulated by the IRS. So they require everything to be under the deductible. Let's start with that. Everything has to be under the deductible. The original provision said primary preventive services, like primary prevention, not secondary prevention, could be excluded from the deductible. And then what Treasury 2019-45 said is 14 more things could be excluded from could be made pre-deductible. It's not saying they were required to be. So I mention all that because health savings account, high deductible health plans that don't have health savings accounts are not regulated. So if you're a large employer, you're purchasing from a large national health insurance company, you could get a high deductible health plan that does have all these things already exempted. So it's the push that Katie is trying to do is to say, let's at least get high deductible health plans that have health savings accounts even allowed to exempt these things from the high deductible. And I think that might be where the effort isn't to say, let's make these things free under the deductible. Now, employers can do that, but it's to say, let's just even, it's not requiring them to be free or low. It's just saying that they can be. So that's, I think, the nuance. Katie and Steve might have better ways to explain that.
Katie, you have a take on it as well?
I do. So I think this is a really important distinction, and I'm so glad that you answered the question as you did, Frank. So the work that the Smarter Healthcare Coalition has been doing, to Frank's exact point, is really to just allow the flexibility to offer more chronic disease prevention pre-deductible, right? So we're not proposing a mandate. And I think that's also what's so important about those survey results that I mentioned earlier. There was not a mandate that you have to offer insulin pre-deductible. There was just we removed the barrier that said that before you couldn't offer these things pre-deductible. So we just said, hey, employer health plan, you know your populations most likely pretty well, and you know what should be offered pre-deductible and what will benefit your populations if it is offered pre-deductible. And so that's why it's so, I think, remarkable that between 75 and 80% of employers said, you know what, we're going to use this flexibility and we're going to decide to offer it pre-deductible. And for the most part, they did not charge cost sharing. Some people did charge cost sharing. They still had that option. But the key there was that because these plans are so regulated by Treasury and IRS, we just wanted the flexibility. And that was what we were advocating for. I think, and why we're focusing on this so much is because, you know, a PPO plan or a plan that has ended up having a high deductible, but is not technically coupled with a health savings account, they already have the flexibility to offer what they would want on a pre-deductible basis or to carve certain things out of the deductible. But the HSA eligible high deductible health plans are the ones that for which we really needed to be granted that flexibility by either Treasury through the guidance, or there are also legislative endeavors underway as well.
Got it. Great answer to that question. Jerry Kluel has a couple of questions about PBMs. I'm not going to get into all the details there, but basically, Jerry's saying, can PBMs kind of game the system here insofar as high deductible health plans and so forth to kind of offload some of their financial risk? And by the way, are there any efforts being undertaken to pass discounts from list prices to consumers with full transparency, which does not exist today? So can any of you kind of comment on where PBMs sort of kind of arrive into this space and what impact their key industry role might have? PBMs. Steve, what do you have? What do you think? Do you kind of model PBM's role in this?
I have not usually, because usually I focused on more the medical care side of it, more so than the PBM component. But that said, it really will depend a bit on if it's employer sponsored, how is the pharmaceutical benefit managed? What's the separate PBM contract? I mean, I, for example, am in a high deductible health plan for my university. I practice what I preach. And so, but the PBM design is almost entirely excluded from that high deductible design, the way that they've set it up as an employer-sponsored plan. Whereas if you wanted to take it strictly in the sense of insurance, it shouldn't be actually. So it does, I think, depend upon how someone wants to deploy in the self-insured ESI world. That said, in terms of the rebates and passing them discounts, hard to say without having that data to see exactly what would go on in that space. That's really a benefit design manager question more so than an economist.
Well, when you're thinking about behavioral response, to the extent that patients, including many with chronic diseases, have choices to make about very expensive drugs and whether
Right.
they're, pre-deductible or not, what the out-of-pocket costs are, payments and so forth. That's got to affect their broader behavior as well for what healthcare they seek and so forth.
I would, well, again, quick comment. I mean, if the plan is selecting, for example, for the provisions that came out in 2019, we have things in there for SSRIs for depression and things like that. That would mean that they should either have very little cost sharing or no cost sharing, and that would translate through to whatever their PBM model would be. It should be, if that's how they want to, enact it. But again, to Katie's point, and Frank's, it gives them permission to do that. It does not require them to do that. So,
point well taken. Good, thank you. I want to give you each a closing question. Please answer in less than a minute, and 30 seconds is even better. So, Steve, Katie, you've been in this, as you've just said, more than 20 years each. Frank, you've been racking up a lot of time and studies as well in here. What should we now look for? What should we look for? Your audience should be watching out for with regard to high deductible health plans, insofar as what they're going to look like 2 years or 5 years or more. Watch this space. What should they have their antenna out for? Frank, we'll start with you. What should I be looking for insofar as what happens to the HDHPs over the next several years?
Well, as a researcher, I'm going to say follow the evidence. There's good studies coming out about the effects of high deductible health plans on increasingly sort of smaller and more vulnerable populations. And if we find that those populations are at risk, let's get the benefit design, the evidence-based benefit design that takes away that risk. So I'm going to say follow the evidence about high deductible insurance.
Follow the evidence. Thank you very much, Frank. And over to Steve. What should we watch out for, Steve?
Two things quickly. I mean, again, to Frank's follow the evidence, the GLP-1 question is going to be kind of interesting. There should be claims data to see who's getting it, what it's doing, what outcomes might be there. It'd be hard to actually get the full EHR data, but I mean, that would be something to look out for the next few years. And the second thing is price transparency. The insurers are now releasing that data. It's there to be harvested by a bunch of .com folks that can eventually put it into apps. No one's really gotten it there yet. But the necessary but not sufficient condition has been met for them to do it. And so the question is, let's see what happens.
Got it. Thank you very much. Katie, what do you think?
Yeah, I like the follow the evidence theme. About 70 million Americans are in these high deductible health plans, if not more. That's the ones that are coupled with health savings accounts. And so I think that's a lot of people. And I think the evidence of how much we spend as a nation on chronic disease prevention, I feel pretty good about the odds that we're going to be able to expand the list of things that can be offered on a pre-deductible basis to include more high value care. And so I feel optimistic about the road ahead.
It's good to have that note of optimism. So across the three of you, everyone agrees on following the evidence. Watch to see what happens and how price transparency rolls out, and track carefully the spending on chronic diseases and chronic disease secondary prevention. All three great things. Well, Frank, Steve, Katie, great start to this. You hit on all the notes we needed from you. We know where to find you. And there's some other questions we didn't quite get to, and I think that VBID will be tracking those as well. Thank you all three very, very much. Thank you so much.
Thank you, Cliff.
All right, you were all three great. Great. Thank you. All right, we're now going to move to session 2. And session 2 is enhancing preventive services use in the backdrop of, get this, Braidwood versus Bashara. This is a hot, very important policy issue. There's a lot of political, economic, maybe even sociocultural flack about this one, and people are watching this very, very carefully. Clearly, in the VBID world, what the Affordable Care Act called for preventive services is central, and we really want to take a very careful look at this. And we're very pleased to have Adnan Parek and Nick Bath to weigh in on this for us. And as we did before, Adnan, followed by Nick, could you just remind us sort of your name, title, affiliation, and how it is you have a connection to this issue? Anand.
Cliff, thanks so much. Great to be with you and great to be with Nick on this panel. My name is Anand Parekh. I'm the Chief Medical Advisor at the Bipartisan Policy Center. We are a nonprofit think tank, sort of a U-tank that tries to take the best ideas from both sides to promote health security and opportunity. I provide the clinical and public health expertise of the organization. And I think for those who know me, just to in 30 seconds, or I've spent my last, I'm an internist, primary care physician by background, but spent the last 20 years in the executive branch and now here at the Bipartisan Policy Center focused on Congress, really focused on what I call the 4 Ps. So if you want to improve population health, you got to really invest and prioritize prevention, primary care, public health. And so this idea of sort of access to clinical preventive services, evidence-based ones, high-value services, has really been core to a lot of my work and really the leadership of the VBID team and Dr. Mark Fendrick, working with them has really brought me to today's webinar. So thank you, Cliff.
Thank you, Anand, very much. Nick, over to you. Name, rank, serial number, and how you are in this, your connection to the issue.
Hi, everyone. Thanks so much for having me. It's great to be on this panel with Anand, and thanks so much for Mark for including me. I am currently a partner at Manat Phelps and Phillips, part of the health practice here. Before I've been here for just over a year. Before that, I worked in health policy in the Senate for almost 17 years. Basically, all of that time with the Health Committee. I started on the Health Committee with Chairman Kennedy and worked on the drafting and passage and implementation of the Affordable Care Act. After he passed, Senator Harkin took over the committee, worked for him, and the last 8 years I managed the healthcare team on the Health Committee for Patty Murray from Washington State. So I've done a lot of work, and you know, I should give a shout out to my previous panelist, Katie Spangler. We worked closely together during those 20 teens years, and so happy to have her involved in this space. You know, working for Tom Harkin, the value of prevention and the importance of preventative services were sort of hammered into my head every single day. So great to be here.
Nick, is part of your job tracking things like Braidwood? And do you have any particular role or stance or clients engaged here? Just want to understand where you are relative to the issue.
Oh, sure. Great. Thanks so much for that. I should have mentioned that at the top. You know, I work on a lot of the, we have a lot of clients here who are very focused on, you know, sort of the federal insurance market regulation and the commercial market, both plan and health system side. You know, I've also, you know, we're also trying to work together with Mark and others, I'm sure, on this call, as well as, you know, private sector stakeholders to put together sort of a coalition of the willing on possible legislative solutions to the Braidwood case. So feel free to reach out to me after this call or anytime if you have interest in that.
Thank you very much. So Anand, back to you. You're a researcher, you're a doc, you've got several kinds of interests, certainly in value-based insurance design and so forth. What's your set of perspectives vis-a-vis the role of Braidwood versus Becerra and your outlook? Can you kind of give us 8 or 9 minutes on that?
Yeah, well, so I'll make just 4, I think, initial points, and then I'll turn it over to Nick to talk a little bit more about the court case and where it is right now and where it's headed, the implications, and perhaps where it may go. But just to level set, Cliff, I think, for our audience, and I think, you know, I think most of the audience, you know, knows this, but I am still often asked here in DC, you know, does prevention work? And let's just focus on sort of the clinical piece here. As you all know, there's a tremendous evidence base with respect to clinical preventive services. So whether it's immunizations or cancer screenings or substance use counseling, sometimes they don't work as well as we'd like, but there's absolutely a tremendous amount of evidence There are also rankings out there, not only bodies like the U.S. Preventive Service Task Force that recommend services, but also bodies that sort of ranks a lot of these services based on how much of the clinical burden does it prevent, how cost effective are they, and services like childhood immunization, screening and counseling for tobacco and alcohol use, colorectal cancer screening, cervical cancer screening. All of these are just examples of really high value evidence-based preventive services. All of them have sort of a different sort of benefit potential, if you will. Some of them may save money. Most of them don't save money, but they're really cost effective. And so that's sort of just a level set that this really matters. These services save lives, they improve health, they reduce illness burden, and they really work. And so I think that's sort of the first level set. I think the second point I just want to make at the outset is, in spite of them working, our uptake rate in terms of what is recommended for Americans, we are not doing great. In fact, we do pretty poorly. Now, all services, are a bit different when it comes to, let's say, cardiovascular screenings. We do pretty well. About 70 to 80% of Americans are up to date with the cardiovascular screenings that they need. Cancer screenings, a little bit more variability, 60 to 70%, depending on whether it's breast cancer, cervical cancer, colorectal cancer. But then when you get into, let's say, substance use, mental health, depression screening, SUD screening, counseling, we drop to like 30 to 40%. Immunizations are really all across the board. And we know with sort of the recent politicization of COVID vaccine that, there have been some spillover effects. So depending on the service, certainly the uptake rate change, but as a whole, I think it's fair to say we really don't do as well as we need to. And then if you look at it another way, and this is data from MEPS, which is the Medical Expenditure Panel Survey. If you ask the question, adults over the age of 35, how many people are up to date with everything they need? It's less than 10%. So the last count was about 8%. So 8% of Americans, adults, being up to date with everything that they need in terms of evidence-based preventive services. And certainly, if you're insured, that rate is higher than uninsured. Higher income, that rate is higher than lower income. Urban areas, higher than rural areas. So there are some sort of disparities there. And so that brings me sort of to the third question. This is not a new issue. We have had sort of low uptake of high value evidence-based clinical preventive services for a long time in the commercial sector and Medicare sector. And so the question is why? And so there are lots of reasons for that. So, at one point, it was a bit of a knowledge gap. I think most healthcare professionals know that these are important, but the knowledge gap has been there. Provider priority and systems of care has often been an issue. Particularly, this relates to how we pay for primary care, how we create teams and provide team-based care. So systems of care often get in the way of the provision of evidence-based services. Quality metrics. So we know that quality metrics are, in fact, the currency now that drives value-based healthcare transformation, or what we hope is increasingly value-based healthcare transformation, and quality metrics matter there. And there are questions of how well we prioritize those quality metrics that relate to clinical preventive services and the provision of those services, and have we elevated them enough? Social needs. So from the patient perspective, it takes time, energy to really get these services. So do you have the transportation? Do you have the time? Can you get off of work? Do you have the leave? And then finally, I think, and this is at the heart of our conversation, costs, right? So, and this goes squarely into VBID, and this is squarely what Section 2713 of the Affordable Care Act was really all about, and what Dr. Fendrick and so many of you tuning in today work so hard for those things that work, and that work well, and that have tremendous evidence for. Let's reduce that cost sharing burden, and that's what the Affordable Care Act did for recommendations from the U.S. Preventive Service Task Force, from the Advisory Committee on Immunization Practices, from HRSA's Bright Futures guidelines for women and children. That's what it did, and it has worked. You know, if you look at data over the last 10 years since the Affordable Care Act, removing cost sharing from these preventive services has led to increases in screening for colon cancer, for high blood pressure, high cholesterol screening, vaccinations for the flu, for HPV, and the use of contraception. Not only that, it has particularly the use of preventive services increased amongst those who are financially vulnerable, as well as in minority populations. So this matters, and we know that it likely matters, but there's evidence to support that. And I think that's what maybe, you know, and this is sort of a good segue to Nick. I think that's what makes this case, Braidwood versus Saris, so important, because we know that these are really impactful services. We already don't do very well. The pandemic, by the way, put us even further behind. And here we are trying to really raise uptake, save lives, in some cases, moderate costs, in some cases, reduce preventable healthcare costs. And now, you know, removing this cost sharing burden, which was the appropriate policy, now may be into jeopardy. And I think that is really the risk and the concern here, Cliff. So maybe I'll just stop there. That sort of sets the stage for the actual case, and then let Nick go, and then we'll happy to engage in the discussion.
Now, Anand, just before we do that, though, from the standpoint of a clinician who has studied this and who has outlined very nicely, very clearly, the upside of providing these preventive services with no cost sharing, if the Braidwood plaintiffs prevail in removing the requirement for insurers to provide these preventive services at no cost, do you see a distinct potential for a drop-off in these preventive services? Is that sort of a cloud hanging over us at this point? Do you foresee a significant impact clinically?
Yeah, you know, worst case scenario could be back to the Wild West, right? So depending on the insurer, the plan, the purchaser, you know, who is paying, they could then set their own rules and guidelines. Now, I think, you know, one of the good things here, the good signs we've seen from a lot of the major plans is they support this. They see the benefit for their members, and you know, they continue to advocate and support these services, and people removing, you know, obtaining them without cost sharing. But yeah, I mean, worst case scenario, you know, we could go back to the days where I may recommend, as a clinician, you know, it's now important to get your colorectal cancer screening, and the response might be, well, you know, I don't have the $500 to pay for that, and that's exactly what we were trying to get away from with this ACA provision.
Yeah, it just seems that given the kind of frequency of migration from health plan to health plan in the United States, kind of a continuity of preventive services could be at risk, given that some plans might continue to cover and some might not. But it is good. There's some amicus briefs and so forth from the insurance industry that have kind of weighed in, which are helpful.
Yes.
So Nick, where do we then stand? I want kind of a policy kind of take on this and a DC insider look. What do you have?
Sure. Well, just picking up from where Anand left off, you know, just quickly flashing back to 2009, 2010, which Mark and many others on this call were involved in. You know, to Anand's point, you know, the goal of the preventative services provision in the Affordable Care Act, from the beginning, the earliest days of its drafting, all the way through the final product, obviously, was to reduce cost barriers as low as possible for those interventions which have been shown in the long run to save downstream healthcare, you know, the health and healthcare costs. And you know, the construct, the structure of the legal protection, delegated authority to the United States Preventative Services Task Force to require commercial plans to cover with zero cost sharing A and B rated services by that independent scientific body. And, I think it's worth pointing out that the reason for that delegation of congressional authority to that body was to insulate it from political pressure or the appearance, right, of political influence. And, I think you see similar attempts on very sensitive issues in other areas of the law. For example, the Essential Health Benefits Package, which sets a sort of a baseline benefits package for all commercial plans. So fast forwarding, where those efforts to insulate that process from either the reality or the appearance of political pressure have become its Achilles heel. And so, the plaintiffs in the Braidwood case, which I'm sure everyone's familiar with here, so I won't dwell on too much, but sued in a friendly district court that had been the forum for other ACA-related lawsuits, alleging that the preventative services provision in the ACA was constitutionally unsound under the Constitution's appointment clause. And without getting all Larry Tribe on everyone, the appointment clause requires certain officials who perform certain functions to either be appointed by the president or confirmed by the Senate or appointed by a cabinet secretary. So, and that depends on a finding of whether they are a principal officer or an inferior officer. And setting that aside for a moment, that is sort of the core argument that has succeeded thus far at the district court level and appears poised to succeed in the Fifth Circuit Court of Appeals, which just had an oral argument on March 12th or something like that, if memory serves. No, not March 12th, earlier this March 4th. And there is a subsidiary argument where the district court held that the court held that the plaintiffs prevailed on that score. And so it's not that the USPSTF can't look at preventative services and evaluate them. It's not that the USPSTF has no power. It's just that they don't have this specific power to deem certain preventative services as requiring no cost sharing in the commercial insurance market. So the practical impact of the court's decision, were it to go into effect, and it is currently under stay, would be to allow cost sharing for A and B rated services if the USPSTF acted on those after the date of enactment of ACA, which is post March 23rd, 2010. So we're coming up on the 14th anniversary here. Now, there is a sort of a subsidiary argument I'll briefly mention, which uses as its statutory head or authority the Religious Freedom Restoration Act, in which the plaintiffs challenged the USPSTF's recommendation to cover HIV pre-exposure prophylaxis, or PrEP, as a zero cost sharing item. District court held that violated the religious freedom of plans in some cases under RFRA, under that federal statute. That is also on appeal.
So certain plans that have some religious connection would, because of that theology, I guess, they would say a fair objection to offering PrEP for people at risk of HIV. And that's that particular challenge. But Nick, just back, the plaintiffs here are questioning not the expertise, but the authority of the members of the USPSTF and the members of ACIP to have this, basically what they interpret as an executive authority to say yay or nay on coverage for preventive services. And they're saying that's not their job, that would be the job of what, Congress?
That's right. I mean, there are several ways, and that is a great segue to sort of the recent Fifth Circuit oral argument. The Fifth Circuit has not issued a decision, but the oral argument certainly implies that they will, I think a betting person would say they're inclined to uphold the district court ruling on both counts, both the Appointments Clause violation and the RFRA violation. And much of the questioning during the oral argument surrounded what remedy the court should prescribe. And so, given that they sort of, for example, issue a nationwide injunction on a requirement on these, the requirement that currently applies to plans, simply declare it's unconstitutional and allow plans to do what they will. So, the fact that the argument focused on what the remedy should be isn't a great sign on the merits.
All the attention to the remedy suggests that they're looking for not rejecting Braidwood, but doing something about it.
Right. It seems to me that they've made their mind up on at least the appointments clause argument. Now, the question, of course, then arises, well, how does one cure the appointments clause issue, assuming that the Supreme Court will be in a similar place as the Fifth Circuit in its analysis? And before jumping to that, however, I want to say that many folks who are deeply invested in the importance of this statutory mechanism, do not believe that the Supreme Court should be taken for granted in this context. So I think, very important that we clarify that, that we have a federal appellate court system. The Supreme Court has not been heard on this issue if they decide to take it up. And the Fifth Circuit is expected to make their decision sort of by the end of the year. There's an additional step that could be taken. If the plaintiffs prevail, the government could appeal to sort of the full Fifth Circuit. This was a 3-judge panel. That's known as an on-bank hearing, or they could appeal directly to the Supreme Court. So that's sort of where the current legal arguments stand. I think I will say just a small bit of editorializing that in this one, there are many observers, this one included, who think the appointments clause argument is a pretty uphill battle. And so using that as a sort of segue, to, well, if one were to consider what a solution would be, that solution would generally have to be legislative. As a side note, the Secretary of HHS did, during the pendency of the case, appoint the USPSTF members under his own authority, under his appointment authority, under a fairly esoteric statute. It seemed in the Fifth Circuit argument that the judges did not buy that he had the power to do so, which would again sort of put the ball squarely in Congress's court. So what does that look like? I think while the actual language of such a change would be fairly elegant and straightforward and quite short, the language and the substance isn't particularly the challenge. It's obviously the cause itself and its political viability. And so I'll just list a few things which I think hopefully will provoke some discussion, which is many of my colleagues have talked about before. On the pro side, for reasons for optimism that there would be bipartisan support should a fix be required, there's the obvious popularity of these and health enhancing effects of these services. I mean, they've basically instantiated themselves. They're baked into the cake now. No one expects to pay for these.
They're de facto working. They're de facto admired. People like it.
That's right. That's right. And we've seen, if anything, over the last 15 years plus has taught us that people don't like it when you take away something they already have in healthcare, especially. The duration of their use, I think, militates towards optimism. They've been it's not like this was just a couple of years. I mean, they're well instantiated into both the provider and the patient community's expectations. There's lack of concentrated, powerful opposition, the lawsuit notwithstanding. There's not, in my view, there's not a well-funded, well-resourced, loud lobbying coalition seeking the outcome that the plaintiffs in the case are seeking. And finally, I think maybe one that's a little bit underreported is sort of flipping the intention of the original law on its head into an advantage, which is that fixing this problem would make the process more politically accountable, right? If the intention of the original provision was to shield the process from political pressure, sure, this would open it to political pressure, but it would also open it to light transparency and accountability. However, there are some obstacles here. The very duration, the length of time that these benefits have been in existence, and the fact that they disappeared from your out-of-pocket liability makes them somewhat invisible. That is, just to put it simply, people take them for granted and may not know where they came from. In fact, probably don't. There's very little cost savings associated with them. This is a fairly technical legislative reason. But for a variety of reasons, the Congressional Budget Office is loath to assign this policy large downstream federal savings in the form of avoided medical care, for example, for Medicare beneficiaries. Why? It's a complicated explanation that I would be happy to talk through more, but one of the reasons is that CBO has an assumption, which has been difficult to dislodge for some time, that without the legal requirement, plans will cover these services at zero cost sharing anyway. Now, I think
some suggest that they might, right? There is some evidence that indication at this point that they would be willing to, right?
That's right. That's right. They do. And I think that's important and laudable, and obviously good for people's health. I think what it misses, however, is that, you know, the technology of preventative service development isn't static. And what happens when a screening test for cancer arises for which the price is something unexpected? I think then the plan and self-insured dynamic may look a little different because they have fiduciary duties, not because they're bad people.
Well, you know, it's interesting, Nick, we've already had a question about things like liquid biopsies and so forth. So some screening technologies that are in the pipeline
Exactly.
could be very, very expensive. Now, that all depends on the evidence of safe effectiveness and kind of diagnostic screening accuracy and so forth that would play out. Nick, I really like your point about, I'll call it, you called it empirical instantiation, which would kind of help support this. Question for you, maybe a little subtle, and this arises from a question we had earlier, and that is, these groups, the U.S. Preventive Services Task Force, ACIP, and the people that take a look at this on the behalf of HRSA, these groups were not established to tell insurance companies what to do. They weren't established for that purpose. They happen to be looking at the evidence pertaining to these preventive services. They've already been doing it for years. Congress didn't say that they're going to make the decision. Congress simply said when they have a recommendation, as per the ACA, then Congress requires that those services be paid, be reimbursed.
Right.
So it's not like ACIP and USPSTF are the executive authority here. They're scientific experts, but there's a law in place to say, by the way, if these people give it an A or a B, insurers got to pay for it.
That's right. It's like a self-executing statutory mechanism. That's right. It's not like the people at the USPSTF have a gigantic signet ring that they stamp onto all insurance plans once they make a decision. They just make decisions like they always have.
Right. So Nick, play this out for us if you don't mind. Then I'm going to ask Anand for his clinician's response here. What, as of 14 March 2024, do you, or are you willing to project or forecast a most likely scenario here? I think I kind of got a little drift of it from the business about the appointments clause being a tough one to overcome, less know about RFRA. What do you think is a most likely scenario here for this to play out? If you had to pick one.
Yeah, I think I do think that after a long period of appeal, which, could take to the end of next year, that the appointments clause issue is going to be in Congress's court.
Hmm.
I think that's going to be a challenge for some of the reasons we described, an opportunity for other reasons, just to finish one thought, the question we were talking about CBO not scoring savings because they believe plans might cover this anyway, plans announcing that in spite of Braidwood, they're going to cover these services with zero cost sharing is obviously great for people's health. It's also difficult for the political urgency of the cause.
It undermines it,
Because,
doesn't it?
members who might otherwise be disinclined to take a walk out on a unsteady plank of Affordable Care Act bipartisanness might say, well, I don't need to do that because it's going to take care of itself here in the marketplace. So, I think there's some cross-cutting dynamics here. The only other one I mention is there's sort of in the current divided government, and we'll see what holds in the next presidential term. There used to be, during the lame duck session, not to get too inside the Beltway, which is the period of congressional session after an election, a November election, was often a time when small technical fixes like this could be done in a less politicized atmosphere. I think that, the current dynamic, especially in the House, makes it difficult to project, much more difficult than in previous Congresses, whether a lame duck will exist as a legislating opportunity. That's an uphill battle. And finally, I think the Affordable Care Act's political potency, which in recent years has declined significantly as a force for political gain or loss, is still unclear. And I think with that lack of clarity, there's some people don't want to take risks if the risk-benefit analysis isn't clear.
Got it. So, Nick, play it out for us. I know you weren't avoiding my earlier question because I know you wanted to make those 2 points, but what's the most likely way this plays out if you had to predict?
Yeah, I mean, I think that there would have to be a bipartisan agreement in both the House and the Senate that there's a very clear rifle shot statutory fix here, and that also an agreement that there would be no need to weigh down, freight, sort of Christmas tree this change with other unrelated policy changes. And I think that last part is the hardest part. I mean, the one that just comes to mind from my recent time is obviously, reproductive health politics are extremely sensitive and extremely powerful for good and ill, and it's often extremely difficult to avoid them in a moment like this when there's a legislating opportunity.
No kidding.
So I think, moderate members on both sides, just to answer your question directly, come together, sponsor a bill, introduce it, shepherd it through committee, try to play keep away and reduce any controversial attendant matter, and attach it to a moving vehicle in 2026. I mean, that's my best.
Okay.
That's my best sort of scenario planning there. But yeah.
Well, we'll take that from you. So Anand, Nick just kind of explained a lot of the intricacies, and then we kind of got him to sort of project a possible scenario. How are you feeling now? Are you more or less confident? Are you going to be talking to your insurance companies about coverage if things don't go the right way? And by the way, let's not forget, because I know you're associated with Michigan, VBID Center co-authored this provision, this very provision of which we speak. And so depending on how this thing plays out, one might expect VBID to take one or more stands on a few issues. In any case, Anand, what's your take now?
Yeah, so thank you. No, it was great. Couple of reactions to Nick's comments, and then sort of what I think we need to do in the interim. while this all plays out in the courts and then potentially legislatively, as Nick articulated. The first is in my conversations on the Hill, and sort of what we do here at BPC. I haven't run into any offices that really want to do away with this provision, right? And I think to your point, Cliff, if you poll this, Republicans, Democrats, you ask members, I think in theory they're supportive. They're supportive of preventive services. So I do think this is a bipartisan issue. I think that's sort of the first. The second is, and we've seen it in their statements, but I do think that a lot of the big plans purchasers out there, they're committed to this as well, regardless of sort of what happens with the case. That being said, not everyone in America is employed, by a big employer and so if this goes away, you could lose that uniformity, and there could be a lot of people who might not be able to access these evidence-based services without cost sharing once again. So it does become a little bit of an uneven terrain. The third thing, just sort of a footnote on the CBO, and I'm not sure if this was ever thought to or overall save money. I mean, in most cases, prevention, certainly probably a minority of services could save money, but they are truly cost effective. That being said, I do think that there is some movement for CBO to start broadening their 10-year scoring window to look at a 20 and 30-year scoring window when it comes to prevention. There's a bipartisan bill that actually just passed the House Budget Committee, a 30-0 vote, you hardly get these days, on what's called the Preventive Health Savings Act, which would essentially say, hey, when it comes to these kinds of issues, CBO, just don't look at your 10-year scoring window, look at it 20 years, 30 years. And I think for prevention in general, that would be impactful as Congress looks at these issues. But I just wanted to point that out.
Those are very helpful.
I think, Cliff, so Nick put out there 2026. So I think that the key point I want to communicate is, well, if that's the case, what should we be doing over the next 2 years? I mean, there's sort of the policy track, and I think we need to focus on that. And if the courts go one way and how do you legislatively fix it? But the fact of the matter is, again, as I said, uptake rates are really, really low. And what can we do in the interim from a health perspective to try to make sure that people understand and are able to access the services that they need? And what I do think we need in parallel to the actions that Nick articulated is we need a national campaign to increase uptake of clinical preventive services. And we need payers, and we need employers, and we need provider groups and patient groups and communication and media and government agencies, and irrespective of administration, we need everybody to really come together, increase education, increase awareness, make sure that people understand this. Again, as I said, we got even further behind after the pandemic. But this is something we can all rally around. Who's going to be against this, really? And while we wait for all of this to really, sort of the end game here and what happens with the courts, let's not lose any time. Let's all, from a science perspective, communications perspective, let's all build a coalition to really promote and raise awareness and educate Americans. Clinicians play a big role, but it's a lot more than clinicians. It's you need other well-known people out there and role models and folks who people look to. They can have a big role as well. But we really need a multi-stakeholder coalition, again, while we work the policy track to really try to increase the uptake rate. So that's what I think we also need.
Well, points well taken. Trying to increase the uptake rate for clinical and epidemiological reasons is certainly laudable, but trying to do that against the backdrop of uncertainty with this particular case, and even if the case goes the way that Nick kind of predicted, that does introduce some uncertainty. And I would think that many of your patients, Anand, are among the tens of millions of Americans whose coverage is, if not entirely at risk, uncertain insofar as its scope with regard to primary prevention and so forth and other services.
Yeah.
And without this requirement, there are a lot of potholes on the way. And this
Well,
could be, yeah.
Yeah, well, fortunately, as Nick said, there's a stay right now. And
For
so
now,
again,
right.
you know, my point is regardless of which way this goes,
Still,
you know, a campaign, you know, whether it's addressing some of the other non-cost barriers, whether it's just, you know, helping providers with systems of care and quality metrics, whether it's educating the public, there are a lot of things that we can do while we continue to focus on the policy track to fix this. And, you know, if it needs to be fixed, that we can do to, again, increase access to services and improve health.
Point well taken. It would seem that VBID and its stakeholders and partners have more on their plate now, if you don't mind my saying. VBID, you know, like we said, co-authored this provision. It's now, shall we say, in flux, and there are clinical, economic, and political arguments to be made. I must say that a couple of our questioners really are kind of focusing on the politics of this. One person said, hey, was there much pushback against USPSTF AB ratings before PrEP was included? And the questioner is sort of suggesting that the issue around PrEP with the politics and the theology may have attracted folks to kind of knock down the whole provision. But that the PrEP issue might have kind of energized that. And then Catherine McLean makes a very strong case in her comment, rather than question so much, is that she's skeptical that all plans will in fact cover these services without a requirement, because members can move from one plan to another and not want to help their competitor. Before the ACA, plans understood that these preventive services were net good, but individual plans did not have certainty that they were good for particular individual plans, specifically because if other plans did not cover, they would have additional medical expenditures and so forth. And she went on to say, after ACA took effect, plans were happy to cover these because it was a level playing field relative to their competitors. And so there's some strong market issues here that might mitigate against a favorable or optimistic assumption about widespread planned coverage of these things. Okay, last word. Anand first, and then Nick. What's your single most important take-home point for us as we look ahead to how Braidwood versus Becerra plays out? You can go clinical, you can go economic, you can go political. Give us the last word, Anand.
I mean, I think, look, and Nick alluded to this. I mean, and I, you know, thought a lot about this, written a book about this. You know, when it comes to prevention, oftentimes, you know, we take it for granted, right? Because the wins are often invisible, what we're averting, what we're preventing. And at any given point, there are dozens of issues that we could be working on, we are working on, but I really urge all of yours to really, you know, make this one of your top priorities, really hone in on this. I mean, at the end of the day, we all care about health, and these are services that save lives, they improve health. And so while we wait for, again, you know, everything to materialize with the court case, understanding what each of us can do, whether it's, you know, plans or clinicians or patient groups. I think everybody's got a role here, Cliff, I would say, to ensure that we can increase these, you know, uptake of these high-value evidence-based clinical preventive services.
Point very well taken on. Nick, you got the last word on this. We kind of squeezed out of you a prediction. I don't know if you want to double down on that or have another closing comment. What do you have, Nick?
No, I just want to echo what Anand said, which is I think, you know, to some extent, I mean, the need to build broad political consensus around a clean solution to this issue is very, very high. And I fear that sometimes this issue is sort of a victim of what I'll call the inbox checklist, which I don't know about you, like I sort of use my Outlook inbox as a to-do list, right? But once it falls outside like the first couple of scroll pages, is it really a priority anymore? Does it really exist? And I think that healthcare organizations, profit and non-profit, for-profit and nonprofit, and foundations have a lot of things they care about. And it's without any judgment, it may be possible that with all the things we have to think about these days, this issue is maybe 6, 7, 8, maybe 11 on our list. And I think if we continue down that path, we're going to get to a point where we realize we haven't sort of, to Anand's point, built the foundation consensus, bipartisan consensus foundation necessary to proceed.
This is a cautionary point. Anand certainly doesn't put it 6th or 10th or 11th on his list. I think we can agree on that. Well, Nick, Anand, thank you both very, very much. You brought kind of the clinical expertise, the legislative policy expertise. You sort of integrated those very clearly. We need to pay attention to this. And I must just say as an editorial note, the VBID Center can't like disappear from this, and the VBID Center needs to stay at or near the center of this issue. And I, for one, hope that they will continue to do so. Okay, thank you both very much. At the top of the hour, when we return from our break, we're going to look at enhancing access to essential medications. There's a lot to cover here with what is an essential medication, what are the new ones, how expensive are they, and how are we going to manage these? So we'll see you at the top of the hour, everybody. Thank you very much. We'll get started in just about 1 minute. 1 minute. Well, I think we can welcome everyone back now to session 3. I want to, by the way, thank our 2 first session speakers who were just absolutely splendid. And I also want to thank the folks who've been sending in questions. We couldn't get to them all, and some very good questions came in just after we were starting to close the respective sessions. But I know the VBID Center does have those, and really appreciate the thoughtfulness people are putting into those. And we did try to get to as many as we could. We're now going to move to session 3. And I think that there's another slide that comes up at this point, if I'm not mistaken, showing session 3. Yeah, there it is. Thank you. Okay. Since we've solved all the issues having to do with high deductible health plans and enhancing preventive services, let's add some more work to our desk here. We're going to now look at enhancing access to essential medications. And there's a lot kind of even embedded in the title here, because what are, after all, essential medications? Why do we need to enhance access to them if they're supposedly essential? What's in the way, and how do we kind of go about knocking down those barriers? And I know that everyone's been witness to such issues as what does it cost to get insulin every month? And that's a huge political issue. I think we're also going to hear about things like out-of-pocket maxes and out-of-pocket smoothing. We want to also delve into some related issues on equity and drug shortages, maybe a little bit on cybersecurity, things like that that may sort of mediate how we do gain access to what are defined or will be defined as essential medications. So with that, I'm going to ask each of our panelists to introduce themselves. Stacy Dusazzino, would you get us started, please?
Sure. Hi, thanks for having me today. I'm Stacy Dusazzino. I'm a professor of health policy at Vanderbilt University Medical Center, and I spend an awful lot of time thinking about how people are able to access medications and how insurance benefit designs are set up to make that possible or less possible. So I guess
and your connection to the issue, and then we'll have Inma introduce herself.
Yeah, my connection to the issue is really as both thinking about it as a person who studies the system, the health insurance design, both Medicare and commercial plans in particular, and thinking about that interaction between what people pay at the pharmacy counter and what that means for their ability to actually take their medications as recommended.
And by the way, Stacy, you've spent a little time on Capitol Hill lately?
That's right. I am on MedPAC right now. So, and I spend quite a lot of time reading about and thinking about Medicare payment in particular, and also had a lot of opportunities to interact with different staffers and committees around the Inflation Reduction Act.
Great, thank you very much. Good to know. Inma, can you sort of self-introduce and remind us what your connection to this issue is?
Hi, my name is Inma Hernandez. I'm a professor at the University of California in San Diego. I'm a pharmacist by training, although I don't practice any longer. So I guess my connection is partially from my past clinical life, as well as the research I do now around pharmaceuticals and access.
And tell us, Inma, you've also had some kind of engagement on the political side of these issues. Can you share a little bit with that?
Yeah, we've been working recently on a couple of topics that I'm going to share today about, which are generic reimbursement and shortages, where I've had the opportunity to interact with some of the folks on the Hill working in these issues as well.
Thank you very much, Inma. So Stacy, back to you. I know that one of the things you're going to get into is Medicare versus Medicaid and some related issues, but give us your best 8 or 9 minutes.
All right, so I'm going to start by breaking up my comments into two broad areas when thinking about access to essential medications. And one will be talking more about access to more commonly used high-value drugs, like the ones you mentioned up front. So insulin, inhalers, blood thinners, things that we think about that are used by a lot of people and need to be used chronically. And then I want to talk a little bit about some of these other medications that are big budget items. So gene and cell therapies, CRISPR-based technologies, and also drugs that would be used by a lot of people. So GLP-1s, which have come up multiple times already, the obesity medication. So I'm going to segment my comments talking about those two a little bit differently and where I think things stand for access. So the first is, I think about access as being mediated or, potentially prevented by your health insurance. So the type of health insurance that you have really is how we think about your ability to access your treatments. With Medicaid, I tend to focus less, and I'll focus less on Medicaid in my comments today, except in the gene and cell therapy space, primarily because once the FDA has approved products, Medicaid generally covers those products at low cost sharing for patients. So when we think about access, Medicaid enrolled individuals tend to have fairly good access at low costs. There are always exceptions, but I'll spend more time talking about commercially insured people and Medicare insured people and some of the challenges of accessing medications. One is, if you've been on this meeting the whole time, you've heard a lot about deductibles. That is a key problem for access to medications. So deductibles, you're paying the full price, the list price of the drug. There's also co-insurance where you're paying a percentage of the list price. And we know for many common brand name drugs that the list price is often much higher than the negotiated price that health plan is paying. That could mean that you're paying a lot of money every time you go to the pharmacy counter. It also could mean that you don't know how much money you're going to have to pay from one fill to the next. So your price might jump around. And we see this a lot in Medicare, where even for preferred brand name drugs, you might start out the year paying a copay, a flat fee, and then it jumps up to a co-insurance as you spend over the course of time. So we know that unpredictability can really make it hard for people to know like what to expect at the pharmacy and to budget accordingly. So these are the things that make it, I think, just generally difficult for people to be able to access and use medications as their doctor has recommended. Obviously, we have some changes that have gone into place. So I'll mention a couple of bright spots here on this type of medication. Some high-value treatments are now much more accessible, especially for Medicare beneficiaries. So $35 insulin copay caps. Other states have been passing those laws for commercially insured people in some health plans. Again, it doesn't resolve the issue for many people on commercial insurance, but many states are taking actions there as well. We also have no cost sharing for vaccines offered under Part D. That's part of the Inflation Reduction Act for Medicare beneficiaries, so that improves access to high-value treatments. And the Inflation Reduction Act is also going to stabilize the payment from 1 month to the next. So for Medicare beneficiaries starting next year, there's going to be a simpler benefit design where you can predict your costs from one fill to the next. And there's going to be a $2,000 out-of-pocket maximum. So there are some bright spots when it comes to access to drugs, at least for Medicare beneficiaries. And I think we've seen employers being more creative, thinking about offering some treatments pre-deductible, for example, as we heard in the first session. So there are some opportunities for improvement. I'm going to shift now to talk about a couple of the big picture items, the high cost, high budget impact drugs that we're all going to have to figure out. So, and this relates back to the affordability overall. So when we think about things like CRISPR technologies, gene and cell therapies. We're talking about drugs that are really innovative, very high value for patients, and look to have somewhat durable response, although it's, we are still learning about these therapies. They're millions of dollars per patient treated. So this is a real budget impact. And we also know that this disproportionately affects payers like Medicaid, where they have to deal with a fixed budget. So that puts a lot of pressure on the system to try to figure out a way to pay for therapies. We also know with things like the GLP-1s, the obesity medications, their prices aren't nearly as high per patient, but they're still high. And we have so many people who could potentially use them that they put a lot of budget pressure across the whole system. And though they're highly effective, they're not cures. So they need to be used chronically to maintain benefits. So this is another place where our system is really trying to wrestle with exactly how to manage treatments that have a lot of value, that show a lot of clinical benefit, but that have a massive budget impact. And one of the things that I think is worth kind of wrestling with a little bit is that if, we open up access to all such therapies, that puts a ton of pressure on premiums, which then could potentially make health insurance itself unaffordable for many people. So we have to, when we think about what we're paying for, we always need to remember that, we're not really asking the health insurance company to pay for this ultimately. It gets passed along to employers, to workers, to people who are paying for health insurance. And we need to make sure that those dollars are being used wisely because they're all of our shared dollars, including taxpayer dollars when we think about Medicaid and Medicare. So I will say from a solution standpoint or things that are working through the system there, to be determined on the GLP-1s. I know there's a lot of interest here. There's a lot of question about who's going to pay, how they're going to be covered. But for gene and cell therapy, CMMI has recently announced a demonstration project to do negotiated outcomes-based agreements across Medicaid programs to try to consolidate negotiations better. That's a voluntary model. There's a lot of details to be worked out, but at least there are some concerted efforts to really recognize these high value treatments and drugs that we want to have access to. They could potentially really improve health equity, though, there's a long path ahead, I think, given the amount of money and the number of people that need treatment.
Stacy, and before we go to Inma, a couple of questions. It's very helpful how you sort of divided the universe into the insulins, inhalers, and blood thinners versus the gene and cell therapies and the CRISPRs and so forth. You also kind of talked about the GLP-1s and whatnot. There's been an interesting experience with the Alzheimer's therapies, these monoclonal antibodies that are supposed to kind of go after and eat up all the amyloid plaques and so forth. And I think at least one was approved by Medicare this past year, and there's another one in the pipeline. Do you see sort of a welling up of a critical mass of not most expensive, but medium expensive on a unit basis, but massive population base that could really break the system when it comes to paying for these things? Is that kind of the issue, one of the issues that we're facing?
I mean, it's a really good question because we do see these things coming along, and I think it is pushing us to think harder about how do we really value treatments and have, value-based insurance design principles apply. So one of the challenges is you can debate about the merits of specific drugs. So the Alzheimer's drugs in particular have much modest clinical benefits available for people at a high price. Weight loss drugs have very substantial benefits that are accruing in clinical trials, but they're also high priced and would apply to a much larger population potentially. However, these are really important questions for thinking about, like, what do we all think is worth paying for? What is helping advance people's health? What is producing longer term savings or downstream reducing medical spending? These are really complicated questions, but I think people really, when you think about if we had a cure for Alzheimer's, that would be incredibly expensive, very large number of people to take it. But gosh, wouldn't we be all better off, right?
If you
So we
could
have to
cure it,
figure out
right.
how we would be able to fit that into a budget. I think sickle cell is one where I'm thinking about it a little bit in the same way. This looks like a transformative therapy, but the question of asking states, to voluntarily sign up for a model and try to figure out how to make the math work, even if you had substantial discounts for those drugs, it's hard to imagine states being able to fit that into budgets. And so I think we'd have to really be creative about how exactly do we pay for it and where do we invest in a more of a single payer type of strategy or negotiation, thinking a little bit like how we handled COVID vaccines and treatments, as when we have such innovative treatments that are real breakthroughs for people, should we think about those not as this fragmented set of payers, but in a more coordinated way?
I see. So this sort of new wave of blockbusters, whether they be the Alzheimer's drugs or the GLP-1s or other, it's not just they're very expensive on a unit basis, of course, but now you're saying that we need to maybe take a broader, more integrated look about how do we manage a whole set of new medications like this. And that's a further question. I think you suggested ways of sort of coordinating efforts and so forth and looking at it big picture. So, well, good gosh, thank you very much. Inma, I know that you want to hit on a couple of these issues as well as introduce things like equity, drug shortages, maybe some cybersecurity. You've got some other issues to raise as well. Inma?
Thank you again, Cliff, for the invitation to participate today. So my remarks are going to be centered around barriers to medication access that are not necessarily related to prices and insurance coverage. So this is meant to be complementary of the points that Stacy brought. Some of the issues I'm going to be talking about have happened for years, like drug shortages, and remain unresolved, but others are new emerging issues like cybersecurity.
Right.
The first threat I would like to discuss is the over-reimbursement of generic drugs in some cases by pharmacy benefit managers. So last year, my team and I looked at reimbursement rates for generics in Part D, and we found 16 generic drugs that were reimbursed at least by one Part D sponsor at a markup of 1,000% or higher. So for instance, aripiprazole, which is an antipsychotic drug, has an acquisition cost of 17 cents per tablet, 17, meaning that pharmacies pay around 17 cents to buy one pill of aripiprazole. However, some PBMs like Rite Aid, and when I mean Rite Aid, I don't mean the pharmacy chain, but the PBM, was paying pharmacies as much as $11.7 per tablet, which we're talking about here of a 7,000% markup. Over reimbursement is also pretty common for a generic cancer drug called imatinib. Actually, both Stacy and I have done research on this drug. A tablet of imatinib, for instance, cost around $4 in 2021. However, CVS Health, the PBM, was paying pharmacies over $240 for a tablet. So in a 30-day prescription, we're talking about a markup of over $6,000, again, per 30-day prescription. These practices are concerning because these point-of-sale reimbursement rates are the basis for patient cost-sharing. In other words, if we have a patient that pays 20% cost-sharing, they could be paying 20% of this inflated amount. Some have attributed these high reimbursement rates to potential anti-competitive behavior. I'm not going to go into it because that's very hard to test as we don't have data on post-sale clawbacks. However, I think it's clear that beyond these extreme cases, there's been an extensive body of literature that has described that many times patients pay more out of pocket for generics when using their insurance benefit than if they were to buy generics in cash. And this is the basis for the popularity of the Mark Cuban's cost plus model.
And before you go on, could you just go back over that? Why are patients having to pay so much more for generics in some situations? What's that about?
So I'm not sure if you're talking about, so I like to distinguish between maybe the extreme cases, like what I like to call over reimbursement. And I think there's been some concerns whether that may be PBMs that are integrated with pharmacy chains trying to push profits to the pharmacy side of their conglomerate. But in other cases, I think maybe without concerns for anti-competitive behavior, we see patients that often pay, as Stacy also said, higher co-payments for generic drugs when using their insurance benefit than when paying in cash. And that's just a function of how the pharmacy benefits are set up. So it's certainly an area that, in my opinion, is prime for policy
The
reform.
design of the pharmacy benefit itself.
Yeah.
Got it. Thank you.
I was going to say now that I think it's a nice leeway that there's been some groups that, based on these trends, have suggested that maybe we should just remove generic drugs from insurance benefits, as one can argue that generics are inexpensive and also relatively predictable expenses. I think that this solution is too drastic and too problematic for several reasons. First, we do have generics, like complex generics, that are expensive. Second, if we carve out generics from insurance programs, then less patients will uptake insurance for drugs. Meaning, if we think about removing generics from Part D, then seniors who only take generics will be less likely to enroll in Part D, right? And eventually, when they are actually prescribed brands or specialty products, they will have less access to them. So just to wrap up this section, I think we've spent a lot of energy, a lot of work on thinking about reform of the reimbursement of brand name drugs. This culminated with the passage of the Inflation Reduction Act, which I think brought very important measures in terms of reform. I think it's now also a good time to think about reforming the generic drug reimbursement. Because as I said, and as we're discussing, in many cases, the existing practices of PBMs may lead to patients paying more out of pocket when using insurance than how much the drugs actually cost. The second theme that I would like to discuss around access to essential medicines relates to vulnerabilities, of the drug supply chain. We are currently experiencing a record high of drug shortages with over 300 drugs on shortages. This is not anything new. Shortages have been prevalent. We are just at a record high in terms of number. Shortages disproportionately affect generic products with low prices. And again, this is an example of an access barrier to medications that even if prices are low, patients cannot access the drugs because they cannot find them. The way how we pay for generics is also considered one of the drivers of shortages. So basically, pharmacies and providers get paid the same amount when they dispense or administer a generic product, regardless of which manufacturer is selected, meaning regardless of whether they dispense Teva or Mylan or another manufacturer. So as a result, generics solely compete on price. This generates a race to the bottom in terms of prices that in some cases can threaten the sustainability of the market. And this is particularly the case for injectables, generic injectables, because they are more costly to manufacture than oral drugs. That is because we need specialized manufacturing processes for drugs that are going to be injected in the body. I think that this pricing pressure interacts with the limited ability of manufacturers to raise prices when costs of production increase. This is related to the inflation rebates that we have in Medicaid and 340B, but also to price protection clauses in contracts with wholesalers and group purchasing organizations, which really dominate the market in terms of like a few of them having control of over 90% of the market. So as a result of this price pressure, many times manufacturers lack incentives to invest in resilient supply chains. And in some cases, profitability may be so limited that manufacturers ultimately may decide to exit the market.
Now, is that primarily for generic drugs where manufacturers don't want to invest in supply chains?
Yes, this is primarily for generic drugs, especially those ones that have low prices or that have high costs of production compared to the costs.
Like the injectables, got it.
Right. So there's been a few hearings, if you heard, in Congress in the past few months around drug shortages. One of them actually discussed value-based reimbursement, and they made a reference to Vivid and the Michigan team. in terms of how value-based reimbursement could be used as a potential solution to drug shortages. So we're thinking here of maybe providers getting paid a higher amount when they select generics that come from more resilient supply chains. So as I said, right now, the status quo is that we pay the same for any generic version. The idea would be to pay more for generics from companies that commit to supply continuity standards as a way to prevent shortages. Also related to the vulnerability of the drug supply chain, I would like to discuss cybersecurity. You may have heard that a few weeks ago, a claim processor suffered a cyber attack, and this triggered a nationwide disruption in the ability of pharmacies to process claims, also in the ability of medical practices and health systems to process claims. If we think about drugs, it's my understanding that in the majority of the cases, pharmacies try to dispense the drugs to minimize access issues. And then they were hoping to submit the claims as soon as the system is restored, which I understand is going to be this week. So I think this is one case where luckily pharmacies were able to buffer the effect of the attack in terms of preventing an impact on patient care. And the attack has been limited to a few weeks, also because it sounds like a ransom was paid to the hacker. But otherwise, they could have triggered a major cash flow for pharmacies and health systems nationwide. So maybe although this time major patient harm was averted, that may not be the case next time. Other countries, for instance, have seen cyber attacks of wholesalers that have paralyzed drug distribution for months. This is a huge risk because we have here a market where 3 wholesalers dominate the majority of the market. So if one of them was to have a severe disruption, it could be truly detrimental to patient access. I think that both Congress and CMS are aware of the vulnerabilities associated with cybersecurity, and they are working on it, maybe not particularly centered around drug supply chain, but centered around health system. But in any case, I think this is a new emerging threat to drug access that is unrelated to prices, but that we will have to keep track of in the future. And I'm going to conclude by talking about another threat to patient access to medications that is not related to price either.
We already have so many. You're going to give us another threat?
So I can leave it there too.
No, it's so much. It's just,
okay.
You're so correct about this is a multi-factor problem.
We, Stacy and I tried to organize this talk to have her covering the price-related threats, right? And me covering maybe some of those that we may not think about, but that may be important issues. So I will just finish by talking about pharmacy deserts, which are proliferating and are becoming increasingly common and are really important for equity because we know that the recent trend of pharmacy closures have affected independent pharmacies disproportionately, and independent pharmacies are more likely to serve rural and underserved communities. I think we need to think about the relevance of having pharmacy access as we talk about drug reimbursement and reform. So increasingly, the drug market is going to be divided into generic drugs and specialty products, right? And small molecule brand name drugs will be represented a smaller share of spending. So if we have patients getting generic drugs from Mark Cuban and specialty drugs from mail order pharmacies affiliated with PBMs, do we really just expect pharmacies to remain open when we need them to get COVID vaccines? I'll leave you with that. So in summary, I talk about some access barriers to medications like high out-of-pocket costs for generic drugs, cyber attacks, drug shortages, and limited spatial accessibility to pharmacies. This is not meant to be a comprehensive list of access barriers. I know, Cliff, you already said I had too many, but just a sample of some new and some prevalent issues that threaten patient access to important medications beyond prices, and some issues that, in my opinion, are also prime for policy reform.
Thank you so much, Inma. You know, it's just that at least going into this, I thought I was aware of all the access barriers, but you've really fleshed that out and added some more. This cybersecurity thing which hit Change Healthcare, which is a subsidiary of United Health Group, far-reaching issues there. And people are concerned that they had too much of the market. And if you can knock out a Change Healthcare, you knock out much of the system across the country. So maybe they had too much power, too much of the market. Stacy, back to you. Just want to ask, you know, I recall over the many years that a basic tenet of VBID is that patients don't really care about kind of the posted price of a drug. They care about how much it's going to cost them out of pocket. So when we talk about price transparency, Stacy, what would really make a difference? I'm just wondering, as one of our questioners pointed out, Jerry Kluhl pointed out very nicely, even if you have these things posted, that might not solve it. How do we get price transparency that is meaningful to patients?
Yeah, that's a great question. And I guess I'll tip my hand that I am not that fond of price transparency for helping patients to shop around, because often they're just bound by their health insurance. So unless you're filling a generic, and you can do things like search for, you know, a discount price, which pharmacy has the best price, usually you don't have all the information that you need. So for example, if I go to the doctor, they'll often ask me, oh, are you still going to this pharmacy over here? And they put that in. Maybe that's not a preferred pharmacy for my plan, but even I, as a drug policy expert, might not know that specifically to be able to say, no, route it to this other place. That's the best deal. And so I think that we often try to give consumers tools to find out more information about prices, but it asks them to actually know a lot more than the average person would know. So I feel like we need to set up policies that make it easier for people to know, like, what is the preferred thing to be doing. So it's one reason I like VBID and things like reference pricing for health insurance benefits, where you say, here's the plan's preferred treatment for you. It's no cost, or it's very low cost, and everything else is relatively higher cost. So I think if, you know, to whatever extent we can set up policies that make it easier for people to just go on with their lives, get the medications that they need, and be kind of nudged to the right choice when there are multiple choices to be made, I guess that's my preferred way of managing the system, just because the information needs are so high to be able to get this right.
Point well taken. Inma, would you agree with that with regard to across various population groups as well, the ability to kind of sort of navigate the system, even know what questions to ask, to even get at the real meaning of price transparency? Do you have a take on that?
I think Stacey's remarks were right on point. It's very content dependent, and it really depends on how the patients access drugs. So
Point well
sometimes
taken.
when we talk about drug access, we put everything together, right? The specialty brand name generics. But as they were saying, the point of transparency is really different, because there's major differences in the way how we pay for drugs. And that's why also I made the point that we work a lot on brand name reimbursement, but that doesn't mean that we don't need reform in some of the other aspects.
Absolutely. I need to pose the question that Patricia Anstedt posed to us. It's kind of an obvious question. It's a perennial insofar as policy, but she says, look, many drugs cost less in other countries. Why can't the United States get prices down? What would that take? And Stacy, maybe to you first, did the IRA sort of start getting at that with the top 10 list? I mean, are we anywhere near that? What's the big differential, by the way? Why Western Europe, other wealthy countries, pay far less for drugs? What's the big difference here?
So one of the big differences is the fragmentation of the US healthcare system that results in not having a single large purchaser, because overall the US purchases far more drugs than any other country. But when you break it up into each state Medicaid program, and then the federal government covers Medicare, and then we have commercial insurance companies, and so you end up with a fragmented payer setup where no one has quite as much leverage in negotiations. And there's also, I think, just been a lack of political will to do something. You know, these other countries will say, well, here's the line in the sand. This is how much we're willing to pay for this drug, or it's not on the national formulary, period. And companies have to decide, are they going to walk away from selling their drug in those other countries if they can't meet that price? And we are a country that loves our choices. Like, we want to have access to everything. So we don't want to make those harder decisions about restricting access or saying no, which then means that we have kind of not great access to a lot of things that are really high value treatments. So our lack of willingness to make decisions at this higher level and negotiate more is putting us in a bind. And, to your question about the IRA, yes, it's starting to go down that path for negotiations. It's certainly, we're going to learn a lot this year. We'll know what the negotiated prices are for the first 10 drugs in September. And we know there's negotiations underway. So we'll see how effective it is. But you're probably also, at the audience is probably well aware that the companies whose drugs have been selected are all suing to stop the negotiations. And I think depending on the outcome of the election, it could potentially put those negotiations at further risk.
Aha. Although worrisome. Inma, did you want to add anything about some of the cross-national differences in prices and why
No,
we're at a
I
disadvantage?
I think that was on point. I grew up in Europe, and it's exactly like what Stacey said. Like, if you don't agree to a price, you will be out of national formulary in a country where 95% of the drugs are reimbursed by the national health system. So pharma has to make that decision, right? Here, the issue that plans in many cases cannot not cover drugs, or for instance, Medicare protected drug classes, is preventing us from being able to negotiate further. Research from my team and from other teams, we've demonstrated many times that there's lower discounts for drugs that are in Medicare Part D because protected drug classes, because pharma obviously knows that all of them need to be covered. So while those tend to be not very popular policy solutions, one needs to integrate them in the context that it would increase negotiating power that we would need to get further discounts and decrease prices.
So until we have, and no one's looking forward anytime soon to a single payer system, we don't expect that. We don't really have in the United States the big enough leverage to really sort of negotiate with greater power. And without that, it's just very difficult to have any true leverage in that, notwithstanding the top 10 that come out of the IRA, I guess. A question came in from Jeff Levenshirtz. I think that this refers, Inma, to something you said about the overcompensation by PBMs. And what Jeff is saying has to do with litigation. And he points out that the lawsuit against J&J, alleging that the company did not exercise appropriate fiduciary responsibility over its employee health plan, could increase pushback against the overcompensation, Inma, to which you referred. And Jeff is wondering whether you could comment on whether that kind of litigation could make any difference. And I know PBMs have already come up earlier today. They're a very powerful sort of player in this space. Inma, can you respond to that?
I think it's a very interesting event. I think it's going to be interesting to see how it's going to pan out, because they sue the employer, right? Not the PBM. So I wonder whether that's going to lead to maybe employers trying to do a little bit better homework in terms of contracting with PBMs. But that not only happens in commercial insurance, that is happening in Part D, as the results that I described from my study are in Part D, and that's happening under CMS purview. So maybe it's not just employers.
Aha. Well, PBMs are a favorite target of many. Something else that came up actually before the session has to do, and I think maybe Inma briefly mentioned 340B, not sure. So 340B program was designed to do something with wonderful intentions. The idea behind it was wonderful. And we know that for various reasons, including hospitals that didn't originally qualify for 340B are buying clinics and so forth that do. So then all of a sudden the big healthcare provider organization gets the benefits of 340B. Is 340B, Stacey, at this point, helping us or kind of getting in the way of better access and better pricing to drugs? Is 340B working well enough to hold on to it or not?
So I would be curious of Inma's comments here as well.
yeah.
I think the question of who it's helping is a good one. So a lot of medical systems, including those that are large systems that don't really treat people who are underinsured or who are Medicaid insured, for example, benefit a lot financially from 340B. And so it ends up being a massive source of revenue for, hospitals and health systems. And you've seen a lot of expansion of 340B, including through these contract pharmacy relationships. So there's a lot of money flowing through that program. I think one of the key criticisms of that program is the lack of accountability. So there should be making sure that if you're serving people who need lower cost drugs, you're passing those low costs onto them. And there's just no visibility into that. And also the community benefit related requirements that you're using those dollars to actually fund programs that are helping the community and helping to offset other costs. One of the things that I always find is that there are a lot of services that large hospitals, centers that were initially intended to really benefit from this, federally qualified health centers, for example, there are a lot of services they don't get directly compensated for. So the overpayment for drugs is meant to kind of pay for many of those services. But I think it's definitely a runaway train. So maybe I'll leave it at that.
Okay, well, Inma, do you want to catch or stop the runaway train?
I like to think about counterfactuals when we think about 340B, right? So 340B could use some reform, as Stacey was pointing out, to increase accountability of where these discounts go. But when we talk about 340B, are we talking about just getting rid of it? Because I think that's the point of like, it was developed with good intentions, and I don't think maybe, the counterfactual is a wall without that. Is just probably thinking about how we could make sure that the discounts are used as it was originally intended.
Point well taken. So, question then about the kind of high-end stuff. Stacey, you mentioned cell and gene therapy. We talked about the GLP-1s, which they're not $1 million drugs on a unit basis, but they can add up. I think they're $1,300 a month now. Thereabouts. From an equity standpoint, with these kind of cutting edge drugs and so forth, and actually the GLP-1s for obesity might even disproportionately benefit some disadvantaged populations based on patterns of obesity and so forth. Do you still see a large gap from the standpoint of equity to access for these cutting edge breakthrough drugs? Is that still going to be a problem for us? Stacey, and then Inma maybe as well.
Yeah, absolutely. No doubt that there's potential to actually worsen health equity as a result of some of these medications, despite the fact that we know that they actually could disproportionately benefit such populations. So for example, sickle cell therapies have a potential to really help to lower health inequities because of many people with sickle cell disease are Black individuals. We also have like many people on Medicaid. So people where we're thinking about both income, race, other factors weighing in. So the ability to have really transformative therapies for people that could help, dramatically increase like their lifespans, their quality of life, productivity, et cetera, these have a lot of potential, but we know that they're also, being on Medicaid, very difficult for Medicaid programs to figure out how to fit them into a budget. And even when we think about solutions that are being proposed, like the gene and cell therapy model, for example, that's a voluntary model. There's also a potential that states may elect to participate or not based on local politics, based on the demographics in their state. For example, we've seen a reluctance of Southern states expanding Medicaid for many years. Like if there's a reluctance to join the model, then that may mean that people in different geographic areas have very different access to these technologies. So, while on the one hand, it's like, yes, treatments that would disproportionately benefit subpopulations who have been historically disadvantaged and, discriminated against in many cases, that we still have payment concerns. And also, if we think about GLP-1s, those are going to, people who have the resources to pay cash mostly right now, right? So as we're figuring out like who can pay, what benefit designs are going to look like, what employers are going to offer those on employee-sponsored benefit plans, it's likely to be for better financially, able patients who can go and pay cash right now to get first access, and hopefully can expand out to other folks. But then the question is then do we put premiums in a place where the lowest income people in our, where we're employed in our communities can't afford even to pay health insurance premiums?
Point well taken. Inma, would you concur?
I don't think I quite agree on this one, because precisely the reason why they are going to exacerbate inequities is because of lack of insurance coverage. And you mentioned, Cliff, like a price tag of around $1,200 per month. That's before discounts. After discounts, we're talking more probably on the $400 to $500 range. So now I want to ask you, if we had a therapy in the price range as effective as they are for cancer, do you think it wouldn't be covered? So I worry a little bit that the reason why this is not covered is because it's for obesity and there's a stigma around the disease. Because again, like I hear the prevalence of the disease, but as a pharmacist, I think these drugs have quite an impressive therapeutic profile, a price point that after discounts, I think it starts to be reasonable when we have demonstrated risk reduction in hardcore outcomes like MACE, major cardiovascular events. So I'm just worried that the reason why they are not covered is truly because of the indication they are approved for and the stigma associated with it. And I also feel we cannot pretend to be serious about health equity and have these conversations around coverage of these drugs that clearly have a disproportionate, that are indicated for diseases that have a disproportionate burden for underrepresented minorities and underserved populations.
You make a very powerful point, I must say, Inma. And Stacy, the two points you made complement each other very, very well. All right, very quickly, I'm going to say this. I'm going to give each of you a coupon. The coupon gives you one chance to pull a policy lever that would increase access to essential medications. Giving you this coupon, what's the one, if you could change one policy, pull that lever, push that button on a single policy within the next 2 to 5 years to increase access to essential meds, what would you do? Stacy, what would you do?
So this is completely pandering to this audience, but I would do more VBID. So I would really push us to think harder about the coverage and the cost sharing based on the value of the treatments that are intended to be covered. That means really focusing a lot on low value treatments and making those less accessible, less likely to be covered. Stop spending so much money there, start spending more money on the things that really benefit patients and get the outcomes that we want.
Thank you very much. Can't argue with that. I mean, VBID was in on the insulin cap thing too. They had a large role in that. So thank you for that. Stacy, Inma, what lever would you pull?
I'm between two. I'm going to say PBM reform to improve transparency, because I think that would lead to some savings. And the other option I had was the GLP-1 coverage, but I don't want to use my coupon card for that after the FDA news last week, because I think now those concerns that I had around indication are probably going to disappear as it's been approved for cardiovascular risk reduction. So I will explain why I didn't use the coupon like that.
Okay, well, you're being very kind of careful and value-based in your decision-making about using up coupons. Thank you. Well, Stacy, Inman, this has been wonderful. We got a lot out of you in 45 minutes, I must say, very valuable. And we always appreciate your expertise. It was a great combination to have you both on this issue. Thank you both very, very much. Thank you.
Thanks so much.
All right.
Thank you.
Well, we're going to move on to session 4 now. And I think many of you see a few familiar faces up there. The purpose of this session is to ask the question, why in the world is it so hard to reduce low-value care? And I'm going to ask Mike and Josh to reintroduce each of themselves. And I know that they've got their paws in this issue among many others. And I just want to make sure that both Mike and Josh tell us what it is they do on a daily basis or thereabouts that touch this issue. And then I know we're going to get kind of, Mike's going to give one sort of type of perspective, and Josh, is going to give a different kind of perspective, but I think you're going to see some resonance when you kind of put their perspectives together on this difficult and biting question. Mike Chernew, let's act like no one knows you and tell us who you are and what your relation is to this issue.
I am Mike Chernew, and I think Stacy summarized an early conversation I had with Mark. It hangs on VBID, where we basically said just what Stacy said. I think it was probably 2004 or 5, where we founded the VBID Center. We said basically what Stacy just said. Why don't we try and make sure there aren't financial barriers to high value services, and maybe put some barriers to low value services to help us offset the cost of funding the high value services. And that therein lay the basic idea behind VBID. And I have been working with Mark on this, co-founded the VBID Center with him. Since then, I've done a lot of work with Mark on benefit design. And now, of course, I do a lot of work on payment reform. And so I am thrilled to be here. I'll say more when I start talking in a minute. I think it's
okay, Mike. Well, thank you very much. And then Josh.
Yeah, good afternoon, Cliff, and thanks to Mark and the VBID Center for putting this panel together today. Yeah, I'm Josh Famer. I'm the Assistant Director for Plan Strategy at Minnesota Management and Budget. Our team supports the health insurance and other benefit offerings for Minnesota state government employees, retirees, and their family members. Specifically, my team, we manage the procurement, data analytics, network tiering, and policy development functions for our programs. We have a fairly large group. We have about 130,000 members in our health plan, making us the largest employer purchaser of healthcare in Minnesota. On VBID specifically, since 2018, we've administered a VBID program for diabetes, making diabetes drugs and drugs related to diabetes care more accessible to members, as well as medical services, labs, and equipment. So we've been really proud of that work and in our partnership with the Michigan VBID Center. And then on the low value care piece, which I think is why I'm in this panel this afternoon, we issued a medical plan administrator procurement last year that included a low value care component that I'm excited to discuss this afternoon.
So that's great. So Josh is going to give us kind of an instance of trying to do something about low value care, what has worked, what has not. So the outlook from a particular well-known institution. And then Mike, kind of more big picture, like why do we get into this in the first place? Big picture, what has worked, what isn't? Are you happy with it? Have you been disappointed, Mike? What's the outlook for any further success? Mike Chernew, we're very anxious to hear you. Please proceed.
Yeah, I've been texting Mark for much of the day about how good all of the various sessions have been, and all we've really agreed upon is now with me speaking, there's nowhere to go but down. So I'm quite conscientious of that. I'm gonna come at your question, Cliff, by following what Frank Wareham did at the very beginning and lay out sort of 3 questions and then get to I hope the broad answer to yours. Frank had 7. I'm going to stick with 3. So there's a bunch of stuff in the low value care space that we've been asking for a while. The first question has been just how much low value care is there? And of course, choosing wisely really helped us define what low value care is. There's been a lot of efforts to measure low value care. We've been using the Milliman Healthways calculator. There's other ways of doing it. And the answer seems to be that there is clearly about 2% of measurable low value care, probably much more than that if you wanted to be more aggressive in defining low value care. But at a minimum, you're talking 2%. It sounds small, but let me say in the grand scheme of interventions to save money, low to mid single digits is really ballpark where you're going to get at, unless you do things more drastic. So I think we have a pretty good understanding now of how much at least measurable low value care there is. The second question I want to talk about, which is going to get to your question about barriers, is how do we get rid of the low value care? That relates to why haven't we gotten rid of it? And there's a lot of issues there. Should we use financial incentives to patients? I think that's hard. A lot of low value care, preoperative testing is not something you're getting patients to really pressure their providers on, things like that. Some maybe payment reform. There's a lot of discussion, do a lot of work on payment now. Maybe that would work. education, the stuff they're doing in Virginia with Beth Bortz and others. Smarter Care Virginia is trying to do education campaigns. Different contexts, different people use different strategies to get rid of low-value care. And you asked, Cliff, why have we not been able to be more successful? I think the answers are twofold. There's a lot of cultural reasons. It's hard to actually change practice behavior. There's a whole field of people that spend their time trying to figure out how to change practice behavior. It's just hard. And then there's a bunch of incentive issues and political issues that make it hard to get rid of low value care. People have a financial interest in many ways in not trying to get rid of low value care. And so there's been just a bunch of challenges that arise in a whole range of different settings. And I think those are probably the biggest barriers. It's been hard to get a concerted group of organizations to really focus on eliminating low value care, although there's certainly some exceptions to that, people trying to say stop the pre-op. So there are some initiatives, but I would say there are big, Josh is going to talk about some. I would say they're probably more the exception than the general rule about where the American healthcare system is.
Got it.
The third question, which I actually want to dwell on, is I think an increasingly important and underappreciated one. And I'm going to give the question in a second. I'm going to pause and let people think about it. I'll watch the chat to see what people say or the questions. Is we're not going to get rid of all the low value care. So let me ask this third question. Since some low value care will remain, who's going to pay for it? Who should pay for it? So option one is providers who deliver low value care should pay for it, at least part of it. And of course, that could be they just shouldn't get reimbursed for it. But it's really the provider responsibility. If they're providing care that shouldn't be provided, why are they getting paid for that care? And now I'm not advocating that as an answer. That's just sort of option one, that the providers should, in some sense, be financially responsible for the low value care that they deliver. Option two is carriers should bear the financial risk associated with low value care because they have a duty in many ways to promote and manage care in an efficient way. And they, as risk-bearing entities, should bear the risk if care is delivered that should not be delivered in a particular low-value way. And it's the carriers who will tell you in a range of other contexts that they have a bunch of care management programs, prior auth programs. I saw a number of RFP responses where the carriers tout their ability to influence care, and that's part of the value add they give to their clients. And maybe the carriers should be responsible for being able to manage care, since many of them are actually managed care organizations. So that's option two, and you may or may not find that argument convincing. And then option three is that the payers should actually ultimately bear the responsibility, the employers, the workers, the taxpayers, because basically we just can't get rid of low value care and someone has to pay. So the workers, the employers, they're the ones that should have to pay, and they should just eat the costs even if the care is not particularly needed. So that's the third option. I find the third option really problematic. I don't believe that payers are the ones that should be responsible for eating the costs of low value care. And that one of the reasons why it has been hard to get rid of low value care is because payers have been willing to eat that cost. And so the system has allowed low value care to persist. And even if it didn't allow low value care, they've paid for it. So if you pay for something, it's hard to motivate people to get rid of it. So I think for a range of reasons, if you were a payer and you were buying turbines, if you're making airlines, if you're buying beef to sell in your grocery store, if you're buying from your supplier a product that's substandard, I don't think you should pay for what you're buying. And I think it's not up to you, the purchaser, to figure out how to make the product that you're buying higher quality. It's up to the supplier to figure out how to make it higher quality, either the provider or the carrier. But that's just my view, and I'll be waiting for the hate mail later. The question then arises, if the payers don't want to be the ones left holding the financial bag for whatever low value care remains, how do they get rid of it? And the answer, I think Josh is going to talk about this in a moment, at least in my mind, has something to do with performance guarantees. All of the contracts between payers and carriers typically have performance guarantees in them. And those performance guarantees might have some net promoter scores in them. They might have some total medical cost trends in them, but they have rarely had tangible low value care measures in their performance guarantees. Now, this doesn't mean you don't have to pay for any of the low value care. You could pay, cut off 1 cent on the dollar, some small savings one way or another. The performance guarantee could be titrated. But you need to find ways for the carrier, for the payers, the ultimate payers, to say, look, there's going to be a certain amount of low value care. We wish you would get rid of it, help patients, have fewer care cascades. But if you don't, we're just not going to pay for it. That's how someone else, the carriers or the providers, have to pay for it. And it has been unbelievably, as we've been sort of pushing this idea of putting it in performance guarantees, there's been a huge amount of pushback. The pushback is typically along the lines of carriers pushback because no one wants to be responsible for that financial risk. So you get pushback from carriers just in general. You get comments, well, the savings are too small. Why do we want this initiative? We're only going to save 0.5% in varying ways. And my view is if we throw out all the ideas where you're only going to save 0.5% or 0.25%, you're then going to have no ideas. So I actually think it's not that costly to say that from the employers to say, we're not going to pay, you guys deal with it. And then it's up to someone else to decide what to do. But in any case, the too small, juice is not worth the squeeze argument is problematic. I view a third argument has been, well, we can't eliminate it. And that seems to be synonymous with, therefore, you should pay for it. The whole point of this talk is to break the connection between the argument, we can't eliminate it, to, therefore, you have to pay for it. It might be true that you can't eliminate it. We still don't have to pay for it, or at least that's my personal view. And I am willing to have in this discussion some pushback on that basic premise. And then the last pushback, of course, is you can't measure it. So how can you not pay for it? You're not going to get the measurement right. It is certainly true there are measurement challenges. You won't get it right on overall in all specific cases. But I do believe on average, you can get a pretty good measure of the amount of low value care that is being delivered. And you can, of course, titrate the performance guarantee to acknowledge that there's some imperfection in the measurement. So you're not going to pay for everything that you think is low. You're not going to drop payment completely for things you think might be low value, but you might take off 1 cent or 2, 3 cents on low value care. And that means you're still paying for a lot of low value care. You're just not paying full price for the low value care. And that will help you solve sort of the measurement problem. At the end of the day, and again, I'm hoping I will get, next to all the hate emails I'm expecting now, I hope I can get 1 or 2 or 3 or 10, a groundswell of people reaching out to say, we want to be a champion to work with our benefit consultants to force them and to put into RFP a performance guarantee that centers around low value care. Because while we would like to eliminate low value care, if the system can't eliminate low value care, we don't want to be the ones holding the financial bag of that low value care. And therein lies the question. If you can make the payers not pay, if the payers can agree to not pay full price for it, then I think you will find some of the other barriers for why it's not removed begin to shrink. But we will see. And since Josh is the only person I know who's actually really done something in this space, I will wait with bated breath to have Josh tell people what they have done.
Well, Mike, thank you very much. You have heard all of the pushbacks against trying to reduce low value care, and you have cataloged nicely your rejoinders to each of those. And one of the places you land with some promise seems to be performance guarantees. We will see how that plays out. So let us now, as you just suggested, Mike, move over to Josh. Josh, how are you making it work in the state of Minnesota? What can we learn from your experience?
Yeah, so I think we're a large self-insured employer, meaning that we as the state are bearing the risk for the financial costs of healthcare services and prescription drugs for our population. We're not buying insurance, we're not paying premiums to a health plan. We're paying them administrative fees. So we're just, for us, it's kind of thinking about like, what are the tools that are available to us to address low value care? So like one of the tools, and we've talked a lot about this today, is around benefit design, setting deductibles, co-pays, and certainly on the high value services. And this is something we have some experience with in our diabetes program. We have targeted cost sharing reductions for high value diabetes care. We found that benefit design is a pretty effective tool to boost utilization of high value diabetes services. Benefit design, when it comes to low value care, I think is more challenging for an employer, because like not all low value care is low value for every person in every case. And so in that way, like benefit design becomes kind of almost too crude. It doesn't quite have enough nuance to appreciate that, you know, a vitamin D screening for one person who is otherwise healthy could be inappropriate, but for somebody who maybe has rickets disease or another condition that would indicate like, oh, it's a high value test for that person. Benefit design would get way too complicated way too quickly to build all of those levels into it. So that got us to thinking about some other tools that are available. And certainly like we can communicate to our employees and their family members about encouraging them to see high value providers. We've done network tiering, steering people to high efficiency providers for over 20 years. And we can certainly communicate about like choosing wisely style messages, encouraging doctor-patient conversations around certain services. But ultimately, for a lot of these low-value care services, you know, Mike mentioned the health waste calculator and kind of going through this very long list of services that we've developed measurement criteria over the last several years. It gets pretty hard for us as like the employer to manage all of those situations. So we rely a lot on our third-party administrator TPA relationship. So our TPA, they handle the claims processing, but provide other key services for every self-insured employer in the United States. They often will handle all of the network management. They'll sign up doctors to be part of the network. They'll negotiate provider rates for providers. They'll provide disease management programs. They'll answer the phone calls from members who reach in and have a question about their bill. But they also set medical policy. And I think like this gets into a service that they provide that I would say for us and probably a lot of other self-insured employers is an area that we just don't get into because we don't have the medical directors and clinical staff to determine this should be a covered service, this shouldn't be a covered service. So we felt like with a lot of low value care services that having an effective partnership and collaboration with our TPAs on this issue is really important to tackle it. Like we can't do it on our own in terms of benefit design. We really need to be able to partner with our vendors.
Josh, remind people what TPA stands for.
Yeah, third-party administrator. So it's essentially the health insurance company that we contract with. We pay administrative fees for. We're not buying insurance from them. We're just paying them for their services on a per member per month basis, usually.
Thank you.
And so that got us to thinking more last year. We were due to issue an RFP, a request for proposal for our TPA services. As a public entity, we're required in Minnesota to issue an RFP every 5 years. So 2023 was our RFP year. And we spent a lot of time thinking about what are we asking our TPAs to do? What do we want them to focus on? And some things that came out of those discussions is our performance guarantees. So as Mike mentioned, performance guarantees are really standard practice in these agreements between employers and TPAs. But we hadn't really gone through and done a deep dive on our performance guarantees and determining which guarantees make sense in 2023, which ones might have been more applicable a decade earlier, but maybe performance is topped out, or maybe it's just not a high priority anymore. So we really went through and took out guarantees that were no longer relevant. We kept some that we think are still meaningful and wanted to include in future agreements. And we also went through and added a number of new guarantees. So some of the guarantees that we added are around cancer screening. We had a lot of discussion earlier today about some concerns that continue to exist around out of the pandemic, how far people have fallen behind on cancer screenings. Our population has typically done better than average on cancer screenings, but we have seen a little bit of a drop, and we just want to maintain focus on that issue going forward. Issues like high-tech radiology spending, but also looking into ways to develop some accountability mechanisms around low-value care. So we decided to focus on 3 different measures of low-value care in our performance guarantees. in the RFP that we issued last year. So I think we were going to be, yeah, great. Jordan just dropped in the chat link to our RFP document, which includes all of the performance guarantees for people who want to reference that. But around low value care specifically, we wanted to focus on imaging studies for low back pain, which is a HEDIS measure that's really well accepted, low value testing in labs before low risk surgery, and vitamin D screening. And so in our RFP, we're setting a percentage of total admin fees. So the revenue that our health plans or TPAs would be getting would be at risk in future years of the contract if they don't meet particular thresholds. So that's the way that we set it up. So if a plan does not meet a particular threshold for low back pain imaging, for example, they could lose up to 2.5% of their total fees for that year. So that was the mechanism that we decided to go with.
Josh, can I just stop there for a second? So take us one level down. Let's take imaging for low back pain, for example. You set some kind of threshold. Can you tell us either how you arrived at the threshold and or how you define it? And then that's the performance criterion, correct?
That's right. So we had an approach with setting up the thresholds that we felt worked in terms of timing for our group and our population when we issued this RFP. So what we decided to do, and the way this is set up in the RFP, is that the first year of the contract, there is no threshold. There's no fees at risk in the first year, but we're using the first year to get experience. And based on how that first year goes, that will inform what the benchmark is for future years. So year one, no fees at risk, but using the year one data to set the year two, year three benchmarks going forward. So that was the approach that we took. A lot of this is still informed by the pandemic and just not being sure how much delayed care in 2021 and 2022. We didn't want to use those years necessarily for future years if there was going to still be some pandemic related effects. So that's the reason that we decided to use year one to set the benchmark going forward.
So, and just one more point with regard, whether it's low back pain imaging or vitamin D screening or the others, to what extent do you rely on and are transparent regarding the evidentiary basis for identifying those as low value care, at least in some clinical instances?
Yeah, so for us, it's relying on established definitions and building on all the research work and all the evidence that has been built up over the last several years around these types of services. So what we are using is, for imaging studies for low back pain, is using the HEDIS definition. So this is, of course, gone through the NCQA accreditation process, is a measure that we are adopting. So we're looking for how many people within the first, I forget exactly what it is, but it's like first 6 weeks of low back pain got an imaging study that perhaps wasn't clinically indicated versus those who didn't. So it's like that's the basis that we used. And another point I would just add around, like, when we're thinking about the total dollars for low value care, Mike mentioned cascades of low value care. And I think like that's a really important concept that's been really helpful for us, because when you look at just the dollars associated with just the low value care services, it might be 0.5% or maybe 1% of total costs are on like this low value care. But thinking through, it's like not just the low value care service itself, but what's the other care that could be set off from that service is really important for us, and not just in terms of what it's costing us as the plan, but also members in terms of their out-of-pocket costs.
So you reach out and grab, let's say, HEDIS measures. Everyone in healthcare, or most, know what a HEDIS measure is. It's got some authority that goes with it. You're not kind of making up this stuff, right?
Yeah.
You're just saying we're going to adopt these. Mike, did you have a comment on that? Looks like
well, I was going to say, the places like the choosing wisely recommendations got codified in the Milliman Healthways calculator to do the exact same thing.
That's right.
Now you could decide to be more aggressive or less aggressive. The key point is, if you put this in the performance guarantee, these are guaranteed savings, and you get an ROI, depending on how aggressive you want to be, of multiples, right? This is simply, we're just not going to pay for things we shouldn't pay for. That's easy money. No one has to eliminate their use. They should eliminate their use. They'll be incented to eliminate their use, but no one has to eliminate their use. You're just saving, it's just guaranteed savings. And depending on how you structure your performance guarantee, it's just basically free money to payers, because you know you're not going to have to pay for some set of things, either because they're going to go away, which is great, or they're not going to go away, but you're not going to pay for it. So it's basically a guaranteed ROI that I think in the grand scheme of things is significant relative to other things that you might do to try to make those savings.
So Mike, the way in which Josh laid out performance guarantees that he's doing in Minnesota, do you view that as a model for implementing performance guarantee based lowering of low value care services?
Absolutely. And of course, that's why Josh is here, because we view it as a model, right? Josh has done what I think sensible things coming out of Minnesota, is stuff that I think people should really have done. I think there's a bunch, Jeff Levin Schurz is on the line. You need to find an EBC like Jeff or somebody who will work with you to just harvest this money, as opposed to explain to you why they can't do it. And I just think there's just people like that unfortunately, there's too few of them. If you send me a message, I will connect you to the people that I think will really have your back in terms of trying to do this. But that's just one. What Josh has done is one model. Every organization is going to want to do this in some different way. If you listen to what Josh spoke about, there was a lot of institutional things about how they interact with their TPA, what was right for their population, how they decided on the measures, how aggressive they wanted to be. And in the RFP process, by the way, the carriers could write back, no, we don't want to do this. The key thing is, like when I was chairing the Harvard Benefits Committee, we found that the RFP time was the one time we could actually harvest savings. That's your one opportunity to push your carriers to actually come up with savings in a bunch of ways. And so I think when you get to that RFP process and you're trying to decide what goes in there, you don't want to miss the opportunity to, at a minimum, not pay for low value care. Maximally, of course, you'd like to get rid of it, but I don't think you should get bogged down in can they get rid of it? Can they not get rid of it? I would just start with, we're not going to pay for it. Do the best you can and see what the carriers come back with.
Got it. Speaking of Jeff Levin Schurz, he did put into the Q&A pointing out, reminding us that choosing wisely is basically off the map now because the ABM Foundation stopped recruiting new guidelines for it and so forth. And it seems like Jeff is wondering, Mike and or Josh, does the absence of an active choosing wisely undermine what you're talking about? Or can you just rely on HEDIS measures and go with that? Do you have a take on that?
I think that choosing, unnecessary preoperative testing didn't become high value because there's not choosing wisely. I think the issue with choosing wisely going away is incrementally what more could they get at? And so I think there's still a lot there that you could look at. And again, you could be more aggressive if you work with the Milliman people. And again, Josh, they did their separate thing. You could dial things up, dial things down, pick what measures you want. There's a process. The thing that, again, I wish Jeff could show up on the little screen here because he knows as much about this as anybody. You need to work with a really thoughtful EBC consultant to help you pick out what the measures are and decide what's right for you and your organization. And I think that choosing wisely information remains valuable for the most part, but there's a range of other places where you could get measures of value that you don't necessarily need choosing wisely. It's just, I do believe, and I think Josh said this spot on, you do want to have some backstop justification for what measures you're choosing. Although I have to tell you, some employers that are facing a lot of cost pressures as costs are going up, they're willing to be more aggressive and push the envelope. And you can deal with being more aggressive if you titrate down the magnitude of the penalty. So you might say, we're going to pay 5 cents, we're going to take 5 cents off the dollar or this much away from your admin fees for something we know is low value care. Here's something that's we're a little more uncertain. There's some opioid, a little more uncertain about the measure. We're only going to take a 0.5% off. Like, you can decide to titrate things. It's just you need a partner that's going to work with you to build in a thoughtful performance guarantee. And that's why I think most of the payers have to find the forward-thinking benefit consultants and then reward them in the marketplace. And now the sort of free market economist in me is going to come out. If the marketplace doesn't reward the people that are doing the things that you want the market to do, the market won't do them. And so collectively, you need to have some business flowing towards organizations or some demand of those organizations to kind of accomplish what people want to accomplish. And there's many things we want to accomplish, but reducing low value care, or at a minimum not paying for it, is reasonably high on my list.
So Josh, do you concur with Mike's titration way of looking at this insofar as how strict you are with a threshold versus or balance against how tough you are on how much less you're going to pay? Does that kind of titration consideration work in your environment?
Yeah, I think it's going to work differently for different employers. And some employers like us, we have, you know, as a public sector entity, we have pretty strict requirements when it comes to verifying the performance. So we can't just rely, for example, on our vendors saying, yep, we hit the threshold, we're good, here's some numbers, trust us, it's all good. Like, we have to be on the same page in terms of verification. So that doesn't mean that we have to think really hard about like the system in terms of fees at risk and how we want to set this up that is going to be meaningful and yet also verifiable. So it has to hit that balance. So for other employers, you know, their calculation could be reasonably different. And that, I think that is totally appropriate.
So you're willing to kind of maybe tailor these depending upon what's going on in the market. But Mike's point, again, is very helpful because it's not, you don't handle them the same way every time. You've got to kind of balance how confident you are that it makes clinical sense to get rid of a low value care service versus the penalty you're going to inflict, as it were, on those that don't use it.
Cliff,
yeah, Mike.
I just want to say one thing. Remember, these are requests for proposals. So you're not necessarily saying this is what you're going to do. You could, but you are really rewarding the carriers that are willing to partner with you to deal with low value care. If you want carriers to do whatever you want carriers to do, you need to, you know, most of the RFP processes have a scoring system. You get scored for this, that, and the other thing. If you want to get carriers that are going to help you get rid of low value care in the cascades, or at least not hold you financially accountable, if they're willing to take some of the risk, whatever it is, you need to have an RFP process that allows the carriers that are willing to do that, the carriers that are good at that, the carriers that are working with their providers or whatever it is. You need an RFP process that will reward them. You aren't going to tell them necessarily what they have to do, but you need to give them some consideration in the RFP process. That doesn't mean they win, because there's network issues, there's transition issues, there's all the other performance guarantees. The key question is, should there be no performance guarantees in the contract? And if the answer is that you're not going to put these performance guarantees, that's akin to saying, all right, we'll just pay for whatever low value care gets delivered. We agree you can't stop it, so we'll just be passively accepting of it. Got it.
So I want to get to a couple more questions, and very thoughtful questions coming in. And so one comes in from Adara Citron about, well, I'll just read it back. This reacts to Josh's point about the TPAs. And Adara says, something that jumped out to me during Josh's discussion was that by employer purchasers making demands of TPAs to reduce low value care, doesn't that introduce variability in the requirements for providers, clinicians and others, I guess? When there are different requirements from different insurers, it can be very confusing for providers when delivering care to patients. Josh, does that introduce clinically relevant variability?
I would say it could, depending on how the employer is structuring the requirement for the TPA. So I think, like, what we did in our RFP last year, we're not prescriptive in terms of like what we want the TPA to do to reduce low value care. We're not saying, hey, stop paying for unnecessary vitamin D screening, you know, have the provider pay for it. So we're not saying you have to do this or you have to do that. It's like we want improvement on this area. We're going to reward improvement by not withholding fees if we can do there. And we're not saying you have to do it this way or another way, you know, and hopefully there would be a path that, you know, there could be some alignment so it's not so disruptive for providers.
Got it. Got it. Mark Herzog asks about getting over to Medicare and Medicaid. Mark says, hey, these are great insights, but they're focusing on the commercial markets and employer leverage. That's, you know, the minority, I guess, overall of healthcare spend in most markets, with Medicare and Medicaid being the majority of the market. Is Mike's focus on individual employers being thoughtful about performance guarantees that would be scalable to the non-commercial purchasers, e.g. Medicare, Medicaid? Mike, do you have a thought?
I do, but my head might explode and the whole thing's going to get messy. Public purchasing is an unbelievably challenging thing. I think it's fascinating that Josh is stepping up as a public purchaser. And I actually have heard a lot of states, because states face a lot of pressure, actually leading the way. And so I do think there's some merit there. I do think in the Medicare program, which I know a bit about, we struggle, just collectively Medicare struggles with how to do proper management of care, because traditional fee-for-service Medicare has not been well designed to do that. And what you see in other contexts, let's take Medicare Advantage. Medicare Advantage plans are such that the carrier actually is responsible for low-value care. In a Medicare Advantage world, which is now half of the program, this is less of an issue because now you have delegated. Medicare has said, we are going to push all that risk onto the carriers, and now the carriers are responsible for low-value care, and if they get rid of it, they'll save money. And in fact, they do. There's evidence from Aaron Schwartz about that. Same with ACOs, move into an alternative payment model, which is another place. That is another way of Medicare saying, we aren't going to pay for low-value care. We are going to incent you to get rid of it. And again, Aaron Schwartz's work, he spoke at a previous meeting, I believe, I can't remember exactly, did his dissertation work. It has now been one of the leading voices in how these types of public things can happen. Medicaid, again, is a lot of managed care. So there's ways of doing it, but it is very hard. It is very hard for public purchasers in sort of traditional fee-for-service Medicare and in a lot of Medicaid programs to really be as active and creative as you can be in the commercial side, simply because of some of the rules around public purchasing and some of the things Josh was alluding to earlier.
It does get messy, that it does. Question that came on early, and actually I was puzzled by this as well. Mike, when you referred to the percentage of healthcare that is low value, you said I think around 2%, maybe 1% to 2%. And what I had in the back of my mind, and which Paul Hughes Cromwell raised as well, is how does that square with all the studies we've seen about unnecessary care or wasteful care? And they come in anywhere between 25 and, a quarter and a third of it, like 39%.
So two things.
What's the difference?
A lot of those, that 20 to 30% number includes things like overpriced care, administrative cost things. So I think that 30% number you have in your mind is a bit inflated. The number I would give you of real low value care is probably going to be 10% range. And that's sort of low value care that you might be able to get at. If you look at like variation, for example, the 2% number I gave, which is admittedly a lower bound, and I'll make a point that Mark would like me to make in a second, that's the measurable amount of money that you could really go after in a very practical way. And if the incentives work, you'll get more than that because of the cascades, and you'll get health. But you're going to get that money with very outlay if you do it in a performance guarantee. So you could be much more aggressive. You could ratchet up to, I don't think you're going to get to 30%, honestly. I just don't think that's realistic in terms of what's really identifiable, credible, low-value care. You could get, higher than 2%, no doubt. The Waste Calculator can add some things in. There's certainly different measures you could put in. But my point was really not that the number was small, that the numbers ballpark as well as you're going to do for most other things you do. And it's actually much easier to just not pay for things you shouldn't pay for than it is to try and steer patients to different providers, right? Or I would love to, there's a lot of work on it's the prices. Mark says prices are above this pay grade. everybody would like to pay less, just to be super clear, right? It just turns out that requires disruptions to care and addressing market power issues in ways that I think the performance guarantee approach for low value care kind of gets around. So I actually think, you know, just take the money.
All right, thank you, thank you. Anyway, I'm glad Paul did ask that question. I had the same one in mind. So a closing question here for the two of you, and I don't know if Josh wants to answer it from the standpoint of Minnesota and his folks, and Mike wants to answer it maybe at a national level, but let's pose for just a moment that 5 years from now, 2029, we're all still here and having the VBID summit and we're revisiting low value care. Let's pose for the moment that there was one really notable success in reducing low value care. And everyone can say, look, that was a really big win. That was a really big win. Josh, what would be a really big win up to 5 years from now that you could say, you know, we had the right thing in mind. I don't know if it's performance guarantees or something else, or maybe a particular disease area, but something that is feasible. I'm not saying probable, but it'd be feasible to achieve in 5 years. What might that win look like? Josh?
So I think that there's a couple parts to me. Like, one is developing the organizational commitment to low value care reduction. So that's like both on the vendor side, the TPA side, but also like the employer side. So for us, like putting these in an RFP and into subsequent contract arrangements formalizes a focus on low value care that's a little different than having 1 or 2 meetings a year to talk about it. It's like it takes it up a level.
Mm-hmm.
And then the other piece that would be, I think, a great success is we get enough movement positively on reducing these cases that we retire these measures and we start looking at like what are some other things that we should be focusing on going forward. So that, I think that would be, you know, ultimately the outcome is not to keep these measures forever, but like let's see if we can get some real movement. And once we feel like they're topped out, let's take them off and move on to the next thing.
Josh, just kind of a quick follow-up on that. Are you, given your role and what your organization's doing in the state, are you positioned to be able to identify downstream the next set of things that you want to pursue?
Oh, not yet. But if we're talking 5 years, I'd hope we would be to that point by then. So that's kind of where our head's at the moment.
Well taken. Thanks, Josh. Mike, what would you say? I mean, you always are good at looking at the downside as well as the upside, but here's an upside opportunity for you.
So I think we have the health system we have because the ultimate payers allow us to have the health system we have. And I think success is success where the people that are ultimately paying the bills hold the system that is serving them accountable for what they deliver, including the delivery of high value care and the elimination of low value care. That's the big success. And I think if collectively enough employers could do that, if enough purchasers could do that, and we could move to payment models and other systems where there's accountability in the delivery side, either by the providers and the carrier intermediaries to hold people accountable, success is going to look like a culture change where people are thinking about making sure folks get high value care and their business models are going to be focusing on more high value care, less low value care. Until the ultimate payers can change the rules of the game so that the business models have to be more high value, less low value, we won't get there. And you'll know there's success when people are not saying things like, would like to cut out needless testing, but we need that revenue financially. As long as people are saying we can't cut out needless imaging because we need that revenue, we have not succeeded at holding the system accountable for reducing needless care and promoting high value care.
Love how you stated that. That's great. Now, I'm going to add a little kind of addendum here since you both have talked about the role of employers. Mike, you just alluded to, well, if employers get on board and so forth. Mike and Josh, what's going on in the employer sphere, in the employer space that you think is or will encourage them to take a harder, more kind of pushier line on knocking down low value care? What's going on in the employer space? Mike, you want to go first on that, or Josh? Mike, you go first.
I think the continued excess of healthcare spending over employer revenue is going to force them to increasingly try and figure out how to manage spending. And the goal in managing spending, you're either going to do one of two things conceptually. You're going to lower price or you're going to cut utilization. And the thing about cutting I'm all for lowering price. That turns out to be hard to do given the amount of consolidation we have. So if you're going to lower volume, you want that to be lowering low value volume. And the problem so far has been that employers have other distractions and they're very focused on the HR side of things, that they haven't been particularly aggressive. But when healthcare spending forces them to be, then I think eventually they will have to take this issue on. And I'm hoping we can find some leading edge employers to start now.
Thank you very much, Mike. Josh, more bullish employers? Is that the trend?
Well, I think there's going to be, to Mike's point, like some headwinds in the next few years for employers, because I think we're coming out of a time period where, in terms of like trend and medical costs and how much employers need to spend on healthcare, we were having negative trend in 2020. Very modest increases in 21 and 22, but in 23 and now into 24, due to a lot of breakthrough drugs for rare conditions, and I'll mention GLP-1 so we can hit our bingo card in this session as well. It's just anticipating much higher trends than we've had in recent years. So it's like, an employer needs to hit a particular target in terms of claim spending when we're anticipating all these additional drivers going on. Where are the opportunities to tackle things that do not hurt employees, hurt their family members in terms of their financial bottom line?
So it certainly sounds as though there's some market factors going on that may induce employers to be more demanding of people like you two guys and others on this call to take a stronger stance on reducing low value care, whether it's performance guarantees or other. That could be the way to go. Well, Josh, Mike, it's great to have the two of you kind of do this session 4 and wrapped up in such a constructive way. We always appreciate that. And I know that in addition to the two of you, we want to thank again our splendid expert panelists in all 4 of our sessions. Hats off to Mark and the whole VBID Center for how they organize this and getting such top ranked notch people to hit on all these issues. So with that, I'm going to turn it over to Mike for some brilliant closing remarks. Mike Chernew.
Yes. So thank you very much, Cliff. Susan Lynn, can you advance the slide one? I have a lot of people to thank. Cliff, I'm going to start with you. We've been doing this for a long time. You never age, you never slow down. You have the ability to guide a conversation that is supernaturally remarkable. I have no idea how you do it, but once again, you are exceptional. So thank you.
Thank you.
I want to thank Susan Lynn and Jordan and the whole VBID team. They are absolutely spectacular at pulling this together. The speakers, as I've said, I never ceases to amaze me what a good set of speakers we have. I actually thought, I'll only speak for the panels that I wasn't on, although Josh was great. You guys can evaluate me later. But the other panels I thought were outstanding, and even more to the point, I think the topics picked were unbelievably timely. So I thought we had excellent panels on unbelievably timely topics, and I could not thank the speakers enough for their presentations. And of course, here you see the sponsors. All of this is done. It's amazing how this small team pulls all of this off. None of that could happen without the sponsors you see on the screen. And so I speak for me, and especially for Mark. We're unbelievably grateful all you've done to help push this mission forward. I think it is valuable for the American healthcare system at large, and it's heartwarming to see people really committed to some of the things that Mark and I have been committed to, which brings me to my last thank you, which is Mark, who just does an unbelievably good job of picking speakers, picking topics, engaging with many of you throughout the year about these issues. It is unbelievable how one small organization can punch so far above its weight if you look at the things they've accomplished in terms of making sure people have access to high-value services, essential medications, preventive care. If you just look across the board at the sessions that we had today, you will see this real dedication to making sure that people are not facing barriers to the care that they need. And then to wrap it all together, I think you're going to find that employers are facing this trade-off. We're either going to charge people more out of pocket, shift costs to them, create barriers to accessing all of these needed services, or we're going to find some other way to control spending. And that's either going to be price, again, I'm all for that, or some aspect of low-value care. And I hope we get to a point when we have these meetings where we can say, we're really getting there. I do believe we are getting there, but there's just a lot more to do. So again, thanks to Mark, thanks to Cliff, the VBID staff, the speakers, and the sponsors. Please, if you can find it in your heart to support the VBID Center, please do. It is Giving Blue Day. So again, thanks. And in lieu of Mark wanting to say anything else, I will sign off. And hopefully we'll be in touch with all of you over the coming months.
Thanks, everybody. Great working with you. VBID has a lot more to do. VBID's got a lot on its plate now, even more after today. Thanks, everybody.
Thanks. Yeah.
Thank you, Mike.
Bye.